Good morning, dear esteemed guests, doctors, professors, and the broader healthcare community across the region, and to Organon founders. I am Farouk Shamsjiwa, Organon Finance Lead for Policy, Communication, and Market Access. I have the honor today to introduce Organon, who we are, and what we do. We are a global healthcare company with a mission to deliver impactful medicines and solutions that advance women's healthcare. At Organon, we are keen to address the areas of unmet need that disproportionately impact women. Now, our company has a portfolio of more than 60 medicines and products across a range of therapeutic areas. Led by our women's health portfolio, coupled with an expanding biosimilars business, and a stable franchise of established and trusted medicines. We are present in over 140 countries worldwide, and Organon is one of the only healthcare companies that has dedicated resources for prioritizing innovation in women's health. Now you must be asking, why? Because we know that when she is healthy, she is empowered, she is resilient, and she is prosperous. And so too does her family, community, society, and economy benefit for generations to come. In fact, research has shown that if women participate in the economy identically to men, regional GDP will increase by as much as 11%, and for every dollar spent on family planning needs, $120 in health and economic benefits is provided. These are drastic and wonderful numbers to see. In a nutshell, improving women's health is a critical opportunity for the region to support well-being and ensure sustainable economic growth. Now, despite this fact, for decades, very few companies have dedicated resources for innovation and improving women's health, with only 4% of R&D spending going toward addressing unmet women's needs. And what has this done? This has contributed to a situation where we are today, which is that women face many health conditions with no or inferior solutions. Now, accordingly, we are working to deliver innovation, improve access, and expand choices across women's healthcare sector in the MENAT region, ever since our launch just over 1 year ago. And as part of these efforts, we are investing in contraception, fertility, maternal conditions, and other disorders unique to women, by nurturing a vibrant ecosystem of innovation and research designed to close health-related gender disparities. In short, we are working to change the course of history, and as part of that journey, our goal is to become the #1 trusted partner for women's healthcare in the region. And we invite all of you to join us on that journey. Here to tell us more about today's event, please allow me to pass over to my colleague, George Munir.
Thank you, Farouk, and welcome everyone to this year's edition of the Organon Scientific Congress Across Region, otherwise known as OSCAR version 2.0. This is George Munir, Marketing and Digital Lead for MENAT Region. We are delighted that so many of you have been able to join us for Organon's largest immersive, entirely virtual e-congress, in what I am confident will be a series of fruitful panel discussions that provide critical insights into how we can support better health for women across the region. Over the next 48 hours, we have convened more than 65 leading international and regional healthcare experts to shed the light on some of the most pressing health concerns that female patients and their families are facing across the region, covering Organon's therapeutic areas, namely biosimilars, fertility, contraception, bone and pain, cardiovascular, and respiratory. We would like also to confirm that OSCAR version 2.0 is accredited from Dubai Health Authority and from CPD UK. Besides our panel discussions, this year the event will also feature a spotlight on innovative femtech solutions for the first time ever, focusing on the role women can play in the emerging digital healthcare space. We're also delighted to bring you interactive sessions focused on driving value in healthcare and the pharmacist's workshop on the art of patient counseling. As Farouk said, at Organon, we are attempting to change the course of history. We remain committed as frontrunners to build upon global expertise, experience, and perspective to shed a light on the healthcare issues that matter most to her. But we know there is more work to be done, and we cannot do it That's why we are here today at OSCAR version 2.0. It's vital that we continue working together to introduce and expand access to healthcare solutions that help secure her promise for better and healthier every day for everyone.
Thank you, George. Good morning. This is Nawal Boutekjihad, the Medical Affairs Lead at Organon MENAT. Since 1978, over 8 million children have been born through fertility treatment. At the same time, 270 million women around the world have an unmet needs for contraceptives. At Organon, a large part of our efforts is dedicated to treating women's health concerns such as infertility, as well as expanding access to contraceptives and family planning services, which are critical to achieving the empowerment of women. Our portfolio of over 60 medicines across our biosimilar and established brands pillars focus on fertility and contraception besides other healthcare concerns which impact women. In fact, over the past 20 years, organ medicines have been successfully used to treat infertility. While great strides have been made in advancing reproductive health, access and education remain critical barriers that have been accompanied by COVID-19. At Organon, when it comes to her reproductive health, we are committed to helping her make informed decisions to achieve a better and healthier every day. As such, we continue to invest in reproductive health with a view to expand our portfolio and identify new treatments, diagnostics, and devices built around her needs. And critically, we understand that affordability in the current healthcare landscape is key. That's why we are committed to developing and ensuring access to more unique established brands and biologic therapies that treat a variety of serious diseases and conditions, including biosimilars, fertility, contraception, bone and pain, cardiovascular, and respiratory. In fact, looking to the future, we are ready at Organon to build on a solid foundation of deep heritage and early innovation to grow all our products in partnership with key stakeholders and local regulators that plug the gap in unmet healthcare needs for women and her family members. But we need platforms such as OSCAR in which we can extend knowledge, share our expertise, and ultimately create new partnerships in the interest of advancing healthcare. We are very proud to kick off OSCAR version 2 and looking forward to a very fruitful 2 day sessions. On behalf of Organon MENAT leadership, we would like to thank you for joining us today, and I thank the team behind this special event. Enjoy the sessions.
Hello, everyone. My name is Ran. I'm leading the value demonstration and affordability at Organ and Minat, and I'm proud to be moderating today's session entitled Shaping Access to Contraception and Its Impact on Patients, Society, and the broader community. Why contraception? Because reproductive health and family planning are global health issues lately receiving particular attention from renowned organizations such as the United Nations, the World Health Organization, and Family Planning 2030. Contraception has been identified as an increasingly relevant topic, and despite that, the WHO encourages ensuring access for all people to their preferred contraceptive methods, unplanned pregnancies remain a significant public health issue. So today, we will be talking about the impact of unplanned pregnancies and the role of family planning. We will be identifying some key findings related to our Minat region in particular, and have a better understanding of the USRA program in Egypt. For this, allow me please to welcome our esteemed panelists for today's session. Dr. Mirna Matni, we're happy to have you. Dr. Mirna is the Director of Health Policy and Payer Insights at CCHO, the Center for Clinical Health Economics and Outcomes Research. Dr. Mirna has more than 14 years of experience in the public sector. She worked in the Ministry of Public Health, Drug Distribution Center for Chronic and Life-Saving Drugs, as the head of the committee in charge of receiving those medications. Then she joined the National Social Security Fund as a drug committee member, rapporteur, decision maker in registration and reimbursement of drugs in all therapeutic areas, where she introduced the concept of health technology assessment. She is a lecturer at four renowned universities. She is a supervisor and a reviewer of theses and articles in different international journals, and she has as well several publications. Dr. Mirna is the ex-president of the ISPOR Lebanon chapter, the former president of the Lebanese Order of Pharmacists Scientific Committee, and former vice president of the LOP Accreditation Committee. She served as well as WHO expert in projects related to drug and incentives for innovation. Thank you, Dr. Mirna, for being with us. Professor Maisa Shawqi, we're happy as well to have you among us today. Professor Maisa is an experienced family planning professional with outstanding community research, teaching, and training experience. She is a health promotion and communication specialist with a proven record in project management, leadership, and supervision, and implementation of family planning training programs and research. As Deputy Minister of Health of Population, Professor Maisa collaborated with national and international NGOs to advance Egypt's health and population goals. She supervised large donor-funded projects associated with the National Population Council and the National Council for Childhood and Motherhood to ensure achievement of targets and alignment to Government of Egypt priorities. Dr. Maisa holds a Bachelor of Medicine, Bachelor of Surgery, a Master of Science of Public Health, an MD of Public Health from School of Medicine, Cairo University, as well as a diploma in Total Quality Management in Healthcare from AUC. We're honored to have you among us, Professor Maisa.
Thank you very much. Honors all mine.
Thank you. So just before starting the session, I would like to remind the audience that please feel free to type your questions in the chat box, and we will make sure to reply to your questions as soon as we finish the panel discussion. So I will be starting with you, Dr. Mirna. Could you please share with us an overview of the impact of unplanned pregnancies and how does the situation in the Minat countries look like?
First, Ran, thank you so much for the nice introduction. I'm really happy to be here. At the end of the day, we are all women and we care for the health of the women. So definitely I will be sharing now my slides. And please tell me if it's clear.
Yes, doctor, very clear.
Thank you. Okay, so exactly, Ran, as you were mentioning, healthy women is not really only important for women. A healthy woman will lead a healthy world, because when women are healthy, all the family, spouse, children are healthy. So we want to make our women healthy, and we want to address concerns while really related to reproductive health, maternal death, and other diseases through quality and affordable health services under universal health coverage. That's why the first part, as you exactly said, Ran, it's really the impact of unplanned pregnancies. When we look at the impact, we try to underestimate the impact of unplanned pregnancies, global and also in our region. But if we just look at the impact and on the several levels of the impact, whether it is health or economics or education, yet we see that it's really an unmet need. What is the role of the family planning? What is the role of contraception? And what is the MENAT situational analysis related to gaps, unmet needs, and some key recommendations? Now, impact of unplanned pregnancies, if we just look at the number of unintended pregnancies, this was like a study in 2014 showing 85 million unintended pregnancies all over the world. And we see that from the high number of unintended pregnancies, we have 50% ending up in abortion, and this is really a very high percentage. And with years, numbers are still increasing, reaching a number of 69 million unplanned pregnancies with 23 million unsafe abortion, were leading to several health problems and health costs. Now, what is the impact of unintended pregnancies? Yes, definitely it can negatively affect mothers and also children. So we have adverse health outcomes for both of them. Studies showed that unintended pregnancies and women facing unplanned or unintended, so we can use both words, are more likely to smoke and drink throughout their pregnancy. And even unintended pregnancy increase the risk of maternal death. So this is for the women. And studies showed also that impact on children is really also high, where we face premature birth, and children from unintended pregnancies are overweighted and they have negative physical and cognitive outcomes. Now, besides health, so yes, unintended pregnancies will impact really the health of the mom, of the child, but at the same time, it will affect education, where we see the level of education is lower in women facing unintended pregnancies. The income is lower also, and definitely we have stigma on women facing unintended pregnancies. So we can see that the level, it's a multi-level impact, where unintended pregnancies are impacting a lot education, income, stigma, and health. What about the family planning? So the family planning is there to address those impacts, and family planning would consider the sustainable development goals. So first, if we invest in family planning, studies showed that for every dollar spent on providing modern contraceptives, we will be having $1.4 saved in costs of medical care, because we will have fewer costs related to health outcomes derived from unintended pregnancies. So if you invest in family planning, you will gain a return on investment, so basically economic, but also this will lead to a female empowerment, where studies showed that many women, they feel that contraception allows them to better support themselves and their families, of course. And whenever the women are delaying the birth of the first child, so here women are working and helping the spouse in a family. What about the economic productivity? Definitely studies showed that 71% of women reported that access to contraception resulted in financial stability and better educational attainment. So the family planning is well addressing the negative impact of unintended pregnancies. What about the MENA? Do we have some gaps? Do we have some unmet needs, some key recommendations? So we're gonna dig a little more into unintended pregnancies in the region, exactly as we saw before. So studies show that we have a range of 15 to 58% of unintended pregnancies in Middle East, and definitely the impact is on several levels: health, economic, social, educational. And as we said before, it's not only related to the women, but also to the families, to the communities. And what is interesting is to see what is the impact of those unintended or unplanned pregnancies on maternal mental health and depression and stress. So if we look at the MENA and we try to dig into the literature, we see that we have some discrepancies and differences between several countries where, for example, modern methods are mostly used in Egypt, and we're going to see it very clearly with Dr. Maisa later on. Morocco and Algeria too. Basically, it's mostly linked to really this increase in demography and higher number of population, with setting a clear strategy to have a lower demography increase. Unmet need is emphasized in the literature whenever it comes to Saudi Arabia and Oman. And for others, we're going to look at really this whole definition and findings throughout the MENA region. So the literature review or the science or the studies for the 10 countries in the MENA, when we look at Algeria, Egypt, Jordan, Kuwait, Lebanon, Morocco, Oman, Saudi Arabia, Turkey, and UAE. So we can see that for every country, there is a particular scenario which is linked to the policy, where we want to see if at a national level we have a strategy, a vision, a family planning program which is set. Is there any access legislation? This might be different in the MENA region. Accessibility is also a concern, because here we are tackling the affordability issues. Even if we have policies at a national level, are those products affordable, accessible, enlisted in the formulary? And what about awareness? So if we have the policy set, if we have accessibility and reimbursement for contraception, are there enough awareness to guide misconception related to contraceptive methods? Do we have enough educational information? And do we have a management to reduce the fear of side effects related to contraceptives? Now, definitely differences are there. We can clearly say that from literature and studies, it was obviously it's showing that in all the region, we have gaps in those three, but it might be different. So if we look at, for example, the case of Lebanon, you see that we have a high impact of religion and its role in decision making. If you look at Egypt, so you see that family planning is there, but still the presence and of the fear regarding the impact of contraception and the fertility recurrence. So women are afraid if they use the contraception, what about the fertility recurrence? In several countries also, we can just look at them and see that the only common point between all those countries was the lack of data. So research is really a very important point to enhance data and generation of gaps and key recommendations. So we have in most all the countries high discontinuation rate because of hormonal contraception and side effects. So they don't know how to manage. Basically in Saudi Arabia, some women are relying on advice from families, from relatives. In Saudi Arabia, we have absence of family planning strategy. So basically in Turkey, this is a little bit different because you can find some health policies at a national level and strategies and visions. That's why if we want to set a small summary where we have access needs, policy needs, and awareness, we can look at the table here and say if we're talking about Egypt, and maybe I am emphasizing, yes.
I'm sorry to interrupt you, but we have a request, just if you can a little bit slow down for the translation to be able to translate your speech. Thank you so much.
Okay,
Thank you so much.
Okay, sure. So for the countries, if we look at the countries, and here I will take the opportunity to talk about Egypt because Dr. Mesa will be tackling and details Egypt. So the literature showed and the science showed that yes, the policies are there. So basically, we don't really have a big unmet need in the policy and strategy and vision. Accessibility, yes, because also studies show that modern contraceptives are available, but awareness is needed. Same in Turkey, where we look at, for example, Saudi Arabia, we have to start with policies and awareness before tackling the access part. At UAE level, it's also tackling the three in a very equivalent level. And research at UAE showed that, for example, most of the research are oriented towards nationals, where 80 to 85% of the people are more expats. So what about policies and tackling different research on nationals and expats? If we look at the results of literature, we can see that surprisingly and not surprisingly, so at the same time, awareness could be identified as the highest unmet need in MENAT region. And this, of course, will be discussed, I guess, because it's important to see why studies showed that awareness was really needed in our countries. Policies are needed and access also, but why awareness? Is it because this is really a taboo to talk about contraception, or because we have some cultural or religious beliefs? And this is interesting to dig more into. I will end up with the last slide on key recommendation. In order to say that science, literature, research show that investing in family planning means return on investment. Investing in family planning means tackling three domains. So we have to work on policies and shaping the environment, on access, affordability, and formulary listing, on awareness, on really reducing the sphere of side effects. And in order to succeed, a multidisciplinary role is needed, where the activity and this partnership between healthcare professionals, policymakers, payers, and patient advocacy groups, everyone will have a role. HCPs have really a big role in awareness because women showed that they need time to spend with their physician to have the best advice on what is the best drug. Policymakers will need to really shape the environment and set strategies short and long term. Payers need to be very clear on the enlistment of contraception on their formularies. And patient advocacy groups are there to defend the women's right. And finally, we'll be all happy because we will have a better health for the mother, for the children, and a better economic productivity, cost containment at the end, and cost saving for the payer on the long run, and female empowerment and gender equality. So I will end up by a beautiful sentence. If we want to summarize what family planning is to a mother, so one of the examples of a mother in Kenya, so as a summary of what is really family planning, she said for her, she wants to bring every good thing to one child because before she has another one. I thank you, and I'm sorry if I was very fast.
No, you were absolutely amazing, and we would like to thank you so much for this very informative presentation and compelling overview of the MENAT region in particular. And it's really interesting to see that how unplanned pregnancies affect not only the health outcomes of the mom, but also it impacts the woman's educational and career goal, as well as the children's health and the social outcomes. So thank you so much for highlighting all of those important key messages.
Thank you.
Thank you.
So Professor Mesa, I'm gonna move now to you. And after we have seen with Dr. Mirna an overview of the region, we would like actually to deep dive into Egypt Egypt specifically, and we are curious to learn more from you about USRA program, how this program will help shape access to contraception and improve the health outcomes of Egyptian families, as well as how do you see the role of digital technology in improving access.
Thank you very much for inviting me to be part of this exceptional panel and to represent Pathfinder International in Egypt through delivering the USRA program, which I think is a very robust, very intense, and very powerful program to be delivered in my country. And I'm not biased, but actually I've been there in the system as the Deputy Minister of Health, witnessing how fragmented the services have been delivered, yet they have been bringing about very good results. I'm going to discuss with you today 3 main points, and I've shrunk them into 3 points because of the time issue. So I'm highlighting important figures in the Egyptian Family Health Survey in 2021, and this is the most recent. It's going to be compared with the results of 2014 to tell you where we are right now. I wouldn't go a lot through the barriers to family planning and reproductive health uptake because my colleague Myrna has went through it very nicely, but I'm going to point for a few points there. And I'm going to explain how USRA results are going to increase the uptake of family planning and reproductive health in my country, given the Egyptian situation. So as a result, the results of the Family Health Survey showed a decline in the total fertility rate between the year 2014 and 2021 from 3.5 to 0.85. And I would rather say that this is so peculiar for the family planning and reproductive health sector in the Ministry of Health. Through its, I would say, fragmented efforts, it brought about very good results. And we have also here by age the utilization of the family planning methods. And as we see that towards the left of the slide, we have the age from 15 till 29 being the least users as compared to those between 30 and 44. This is the peak of fertility between 15 and 29, and that's why these are the domain target group that we are focusing upon in the USRA program. Don't be astonished that we have pregnancies or we have pregnant women using family planning methods below 18 years because we have a problem in our country of childhood marriage, and childhood marriage in Egypt is a case for girls and boys, not only girls. Next, we have 20.5% of pregnancies are unwanted, which also reflects a very big demand for the service. And we have the use of the family planning methods in Egypt, reflecting upper and lower Egypt discrepancies. We have non-users reaching around 41% in Upper Egypt and 28.6% in Lower Egypt. On the left side of the slide, we can see that we are actually using modern methods among the users to the utmost in Upper and Lower Egypt. Respectively, and this also represents or reflects the efforts of the Ministry of Health. For the time being, it's only the Ministry of Health work on the ground. We can see also that the introduction of the Implanon or the intradermal implants at the year 2014 has assumed a 5-fold increase in 2021, which is very promising that the community is accepting the modern methods, and the key player right now is the intradermal injectables, and they are also well received in the community. Unmet needs for family planning have been investigated before writing the USRA program, and therefore our program is so customized and it is so encrafted into the Egyptian community, trying to resolve the missing gaps that has been there forever. So we have the cultural disapproval of pregnancy, we have the fertility preferences that are so doubtful and hesitant, we have the perceived no or low risk for getting pregnant, and we also have the method-specific barriers like accessibility, perceived effectiveness and safety, perceived and actual side effects of use, and we have the serious dilemma of couple-related factors, whether it is the male dominance for decision-making or it is violence against women and girls, which deprive them from the right of having the accessibility to the service and sharing in decision-making as well. If we look to the big picture for the main barriers, it has been considered that service provision and coverage is a serious problem in our country, and providers lack knowledge and skills is also another. The great need for the female GYOB, especially so in Upper Egypt, is so detrimental, and it has to be considered as one of the important solutions in the heavily populated governorates in Upper Egypt. And we have the lack or the inaccessibility to the correct knowledge, where the country has been so much reliable upon making TV spots and radio spots and airing them, and this actually costs a lot of money, and it has to be considered. And I think Myrna also has discussed that the dissemination of knowledge is really problematic in the MENAT. Sometimes the upcoming news of COVID-19 in the year 2020 and up till now has interrupted the service of delivering family planning and reproductive health services, not only in Egypt but elsewhere. And we have to be backing up ourselves for the emergency of other similar situations. Maybe I would also go for the pinpointing for countries with civil war or political difficulties. And they have to make themselves aligned with how can they overcome such barriers. Well, this slide seems to be a little bit heavily loaded with information. It is the OSRA framework. And the conceptual framework, I consider it very smart and very to the point, but it is full of details. So I'm going to postpone it in the very end because my slides are going into it piece by piece. Our OSRA goal is going to be achieved through deploying strategic set of customized, nationally aligned inputs. And nationally aligned inputs here actually means that we are working with the government of Egypt and its representatives to help each one achieve his goals within our framework. So we are aligned with the government of Egypt's Vision 2030, with the National Population Strategy formally announced, with the National Family Development Program recently announced here in Egypt, with the Ministry of Social Solidarity-led Haya Karima, and it's one of the wonderful programs currently run in Egypt. And we are also into the universal health insurance, trying to advocate for the acquisition of family planning and reproductive health under the umbrella of health insurance. Pathfinder is leading this change together hand in hand with the National Family Planning and Reproductive Health Program and sector in the Ministry of Health. We have very highly selected private sector partners as consult for the delivery of the training programs for doctors, nurses, pharmacists, and their assistants. We have IQVIA, an internationally recognized digitalization body, and they are going to take over this part. We have Etisalat in Egypt for the mass messages delivery, which is going to be smart and targeting certain segments in each governorate and district. And we are also having two very big NGOs, the Egyptian Red Crescent and the Egyptian Family Planning Association, working hand in hand to deliver the social and the behavioral change theories to the very front, face-to-face, covering for the areas where there is deficient services, and there is no coverage or there are no doctors. And we have the OSPRA team together with Save the Children developing and delivering the social behavioral change there. We have also resource partners to be called upon when needed, and this is going to be left until we are down on the ground in the governorate. We have DKT Egypt, Organon, Technopharma, United Company of Pharmacies, and MSD Egypt. Our work is going to be concentrated in 12 governorates. 3/4 of them are in Upper Egypt, where the problem of high fertility is actually located, and 25% in Lower Egypt. This is evidence-based governorate selection and is targeting high fertility areas, which is in need for service augmentation. So this is a very realistic program. It has been so much crafted to address the serious problems. And as you are going to see right now, how we are partnering with the government of Egypt to replicate. The program is 5 years program, and it actually started in the 18th of August in 2022. The first 6 months of each phase are the preparatory work at the level of the Pathfinder, coordination with the partners, coordination with the government, coordination up till the district level, and starting from the 7th month, we are fully developing the implementation package. And then in year 3, we are scaling up the replication. We're working in 2 districts per governorate, and we are working hand in hand with the government to replicate in other districts, and we are coaching them and maybe solving their problems and enacting them and helping them to reach out for a full-scale replication. By the end of year 4, we are giving a light touch and support and handover and moving off. As you see, between phase 1, 2, and 3, we have like a safe period at the very beginning to launch the system and to go for the same run again for a couple of times. The core concept is improved health outcomes among families through three main results. The increased voluntary family planning use and its continuation. And we are stressing upon voluntary family planning because this is what we are aiming for. This is what is internationally accepted. This abides by all the laws and by all the rules in Egypt and outside. We are into youth equipped with healthier choices and making evidence-based information available for them to shape their minds and their thinking in the future. We are not only working with youth, but we are also working with adolescents because this is a very important phase not to be skipped. We are working to improve the gender dynamics in Egypt, and all this is embraced with collaboration, learning, and adaptation, and it's going to be delivered through the social and the behavioral change strategy. We are into the total market approach for R1 or for result 1, and positive use development approach for R2, social norms transformation approach strongly for R3. That's the improving the gender dynamics in our country. I'm putting here few details because the slides are meant to be helpful for all of us to see what's happening at a snapshot and to think about our own situations in different countries. So we have the integration of the digital technology for improved access to demand for quality of family planning and reproductive health services, information and services, and this is actually going to be discussed in detail in a couple of seconds. We have public-private partnerships expanded to ensure a total market approach, and we have family planning information services integrated in key family health services, not only in the family planning sector only. Youth and adolescents, we are hereby strengthening the life skills and health knowledge that are applied for improved health behaviors, and we are increasing the efficacy of the young people between 20 and 29. Let me tell you that this is the premarital and the marital activity phase, to act upon equitable family planning intentions, to share the decisions, and to understand that women and men are a couple, and the couple is the unit of the family to take on with their decisions that they are in need for. Gender dynamics improved for enhanced voluntary family planning and reproductive health. We have the gender norms supportive of healthy, equitable family planning and reproductive behaviors to be adopted, and to increase the prevention of violence against women and girls through reinforcement of knowledge, attitudes, and behaviors. And here in Egypt, we have the National Council for Women on our partnership, and we are aligned with what they are doing, and we are helping them achieve their targets as well. I'm speaking here about a seriously big digital intervention. It is so robust, it's so intense, it is so modernized, and it is customized for the Egyptian situation. These digital interventions are targeting selected clients. They are the moderate to high education, and it is being accessible for them at their fingertips to get the knowledge that they want at any time. We are also digitalizing the management system either in the Ministry of Health or in the related ministries cooperating with us. And we are offering also a complementary training for the service providers that complements the face-to-face training programs, making the knowledge accessible also for all the service providers. We are having an e-platform, and I'm not going to go into the details of the points here. We are having an e-platform for the physicians and nurses, for making the information and tools and the experiences shared. We are having a website and a blog portal in order to allow for registration and accessing the information. We have social media and mass messages for whole public social media listening management, mass SMSs, and campaigns as well. And we are going into media campaigns, and we are going also into convoys on the real ground to reach the public face-to-face. We have a bloggers hub and at our package, and we have an artificial intelligence-enabled chatbot to respond to the frequent or the common questions which the generations or the target audience have. The online training program is intensifying and is augmenting and is synergistically acting with the face-to-face training that's going to be offered for the physicians, nurses, pharmacists, and their assistants. So it is complementary. It is not an all one way to take it, and it's going to improve their clinical knowledge. It's going to improve their client-provider interaction, offering information and referrals, and it's going to provide also a cost-effective option for the remote supervision. The social and behavioral strategy is not only digital, and I meant to put this slide to tell you that we are going into a face-to-face training that is central at the governmental level and is going to be cascaded down to reach the district level through the cooperation between the central team, the peripheral teams, and by means of the cooperating NGOs, that's the Egyptian Red Crescent and the Egyptian Family Planning Association, together with the different ministries, when we sub-award the small NGOs to work with us with the national councils, we are reaching actually the public face-to-face in the selected 750 sites all over the 12 governorates. We are going hand in hand from an individual face-to-face training, from individuality of meeting the public, considering families and peers, because the family is the unit of the community, and we are going into community leaderships in all governorates and in all districts, and that's how we are going to reach the social, behavioral, and social change. And I'm coming back to my OSRA conceptual framework, which is gonna summarize the whole presentation I had. We we discussed the increased voluntary family planning abuse and the approach of the total market approach that we are going to use. We have customized inputs that's really related to the Egyptian situation, and our expected outcomes is the increased uptake of the family planning evidence-based, and it is information-based decision-making upon total acceptance. And we are also working on the youth, the adolescents and the youth to get our results happening again. And we are also working upon improving the general dynamics. All the planning of this framework is evidence-based, is related to studying how by heart the Egyptian situation and addressing all its needs to be mechanized into action and achieving the government of Egypt goals. Thank you very much.
Thank you so much, Dr. Maisa. This is a very, very structured and impactful program, and we're wishing you the best of luck in the implementation and all the implementation phase. Actually, we're receiving a lot of feedbacks and comments from the audience. They are all thanking you for this very informative session and information, and for bringing up this very important topic. And actually, I think we can take just one question very quickly. We have seen in both the presentation that one of the biggest unmet need in our region is the lack of awareness, right? And we have seen this as a critical component as well in the OSRA program. So how do you think, Dr. Mirna and Dr. Maisa, we need to address the awareness issue, and at what level?
Mirta, would you like to go first?
I will give you a break, Dr. Maisa. The presentation was insightful, so you take just a breathe. So I will start, if you don't mind, sure.
Yeah, sure.
Ran, yes, awareness was really diagnosed like being the most unmet need. And to address awareness, in fact, we have responsibilities and roles at different levels. So I will start maybe by the physician's roles, because I believe that it is the most important one, where the physician guidance on the different different methodologies in contraception, emphasizing the education, the effectiveness, even the awareness of physicians on the risk of abortions on maternal health. And we know that in our region, studies showed that the patients are mostly influenced by their physicians. So physicians are really have a very important role. Policymakers and payers also related to awareness, because as we have seen that studies show loss in really seeing what is reimbursed, what is really accessible. So establishment of a list denoting the types of contraceptives supplied by the Ministry of Health is important. A national awareness campaign where we have the physicians on board, a patient advocacy group advocating for women's health rights on board. The media dissemination also is key, because the media dissemination will help also to direct awareness for all people, underprivileged individuals, a lower educational level. So this will help a lot. But maybe my advice would be is that when you address family planning awareness, we need always to remain mindful of cultural aspects and also the religious beliefs of each country.
Can't agree more. Dr. Maisa, anything we would like to add quickly?
Thank you, Myrna. I would like to say that the Egyptian situation is so unique. We have 30% of the population illiterate. We have 28 million never been to school, and have 7 million dropped out from school. And that's where the digitalization system should be complemented with face-to-face awareness program, and it has to be intensified to reach the people. It has to be customized, to be made simple and clear and easily applicable, to be easily understood, and to comprehend the difficult cultural beliefs, the negative ones, and to reach for the people either through doctors, through nurses, through convoys, including the religious key personnel over there and the community leaders. So this is our package in reaching at the very front line, and we are making the educated, the rest 70% of the population having a hands-on to reach for information. Definitely, doctors are going to be trained on the client-provider interaction. They are going to be trained upon the how to perform a professional counseling, having the awareness 1 and 2, or the we just say the gather. So to greet, to ask, and to tell. To tell is the first counseling one. To tell them in general about the family planning methods and to help them choose the appropriate one, and to explain about the details of each method that the woman has selected and what are the cons and pros. This is very, very definite.
Yeah, thank you so much both, and we're very sorry we need to stop because we're running out of time, and we will see you in the networking session room 2. Thank you for the information, and I hope by the end of this session we are all in agreement that each and every one of us can play a significant role in making an impact not only in women's lives but children, families, and the broader societies and economies. We will see you in the networking session. Thank you so much. Bye.
Thank you very much.
Hello, doctors. Welcome back to the contraceptive sessions in the OSCAR Volume 2 Congress. Today, we have a very rich agenda with eminent regional and international speakers from around the world discussing very important topics in the area of contraception and family planning. And without further ado, I would like to welcome our moderator for today, Dr. Osman Ortashi. Dr. Ortashi is an experienced gynecologist and obstetrician with over 20 years experience in 3 different continents. He completed his training in Cardiff and Bristol. Thereafter, he worked as lead for gynecology and colposcopy services in North Devon Hospital. Also worked with NHS as hospital-based program coordinator for cervical cancer in the North Devon region. He was member of Southeast Lead Colposcopies Committee and member of Devon Gynecology Oncology Network. He is a well-known regional figure in advanced pelvic and laparoscopic surgery. Recently, Dr. Ortashi has been elected to be Qatar's chair of Royal College in OBGYN and a representative of the International Committee. Currently, Dr. Osman is heading the OBGYN outpatient clinic in Sidra Hospital in Qatar. Welcome, Dr. Osman.
Thank you very much, Fatma, and I welcome all the attendees today. As Fatma said, you are all welcome to OSCAR 2, and I can promise you that you will have very rich session as we have very eminent speakers from regional and international speakers. The sessions will be in 3 parts. The first part by Professor Yasser Al-Bishri, then we have 2 other sessions. We will leave Dr. Bishri first to finish his talk, and then we'll have Q&A. The first session, as I said, it's going to be on patient-centered approach to family planning, WHO eligibility criteria by Professor Yasser Al-Bishri, who is a professor of gynecology and obstetrics in Ain Shams University and a fellow of the Royal College of Obstetricians and Gynecologists. He was previously a consultant in Durham, UK. He has a wealthy experience in obstetrics and gynecology. Professor Bishri has a wide bio, but as per his request, we don't want to go through all his bio because he's an eminent professor of obstetrics and gynecology, and we are very happy to have him today. So the floor is yours, Professor Yasser.
First of all, I would like to thank Organon for inviting me, and thank you very much, Professor Osman. Thank you very much for your kind introduction. I'm talking today about patient-centered approach to family planning. Let me start by saying how we counsel women actually to choose the right contraception. There is directive counseling, which means that I would actually convince the patient or the women to take a certain method of contraception. And there is the shared decision-making where we discuss together what's best for her. But we should be moving towards an informed choice. Informed choice means that actually she gets to know all the information properly, and then she decides which method of contraception she would like to use. So it's an informed choice. And this is honestly not just about family planning, but it's about any part of in the field of medicine. The women should have the right for an informed choice. So she knows the pros and cons for every method of contraception, and she makes up her mind about what should she take. Now, there's been changes actually in the contraceptive choices, and the options are changing. And this is a nice graph showing how the percentages have changed comparing year 2002 with years 2015 to 17. And as you can see that earlier in 2002, more women actually were using the pill. More women were going for sterilization, and more women were going for condoms, using condoms. Now things have changed. 2015 to 2017, more women are keen on using an IUD, using implants. It's now 4%, it used to be 0%. The contraceptive ring or the patch, the withdrawal method have actually increased. Natural methods like withdrawal and injectables have been reduced a bit. So women are changing their choices and options based on what's developing recently and the info they are getting. Now, the WHO was very keen on letting doctors and women actually know what's the best method of contraception, and to get rid of the myths, because there's a lot of myths around the use of contraception. So they started in 1996, where there was an in-depth review of the epidemiological and the clinical evidence. And then in 2000, there was new evidence from systemic reviews of literature for contraceptive use among women with certain pre-existing conditions, like women who've had breast cancer, women who are hypertensive, and so on. And then there was the third edition, and this was in 2004. They added the fourth edition, 2009, the medical eligibility criteria for contraceptive use. And this has been modified again 2015 with the wheel, the fifth edition, and finally the mobile application, which I'm going to talk about. So these are all attempts from the WHO to make sure that information about contraception is actually readily available to both doctors and when using it. And the four cornerstones of family planning guidance are the medical eligibility criteria for contraceptive use, the selected practice recommendations for contraceptive use, decision-making tools for family planning clients and providers. So that's both actually for the doctors and for the women. And the family planning, a global handbook for providers. So this was in 2015, the wheel. And the wheel was really an innovation at the time, where you've had, as you can see, different methods of contraception, the medicated loop, the copper, the implants, the progesterone-only pills, and the injectables, and the oral contraceptive pills. And you've had different actual diseases or conditions, like am I in the postpartum and breastfeeding period? There is sepsis, PID, women who've had sexually transmitted diseases, adolescents, nulliparous, and so on. So you put actually your details, and then it gives you a score 1, 2, 3, and 4, whether this is a good method for you or not. Then in 2019, things got actually better, where you could download the application. The application is totally free, so all doctors can actually download the application. And you can, through the application, select up to 4 comorbidities, like 4 different diseases, up to 4 different conditions. And you can show it to your clients if you want. So if you are a doctor sitting in your clinic and you've got this tool, the woman walks in, she's got this and this and this, you can easily click on the application, put the info, and you will get answers for what's the best method of contraception. And it actually gives you 4 different categories, where category 1, use the method in any circumstance, there's no problem at all. Category 2, where you can generally use the method. Category 3, use of method not usually recommended unless it's the only available method. And for 4, you are not allowed actually to use the method. So it's really nice because it comes out with the advice which method you can use. And when you look at the categories for contraceptive eligibility, category 1, a condition for which there is no restriction for the use of the contraceptive method, which means you can use it. So use this method in any circumstances. Yes, please use this method. Category 2, a condition where the advantages of using the method generally outweigh the theoretical or proven risks. Again, generally use this method so you can use it. Now 3, a condition where the theoretical or proven risks usually outweigh the advantages, which means that there is a risk of using this method. So it's generally better not to use it actually, or you should not use it unless there is no other methods. this is the only available method for contraception, then we will have to really think it, have a good chat with the patient. And as we spoke earlier, it's all about informed choice. Finally, 4, where a condition representing an unacceptable health risk if the contraceptive method is used, which means you are not allowed to use this method. Don't use this method. So that's the category 4. So let's see some cases, just simple cases to see how we can use this application. First case is a lady. She's had an implant applied happily, but then when she went with her mother to her breast cancer consultant, and at the doctor's office, of her mother's doctor, he warned her and he told her, you are actually going to develop cancer. And the lady got really terrified and came up to you. So what do you think? I'll just give you 1 second to each of you think. Now, this lady's mother had breast cancer. She applied an implant, and her doctors actually got her really worried. Just, take a second, think about it. Is that okay or not? Can we actually put an implant in a lady whose mother had breast cancer? So let's see. Now you're gonna, put the criteria, and we'll come out with the answer. So as you can see on the right side of the slide, there's family history of cancer, breast cancer. Now, category 1 is for all contraceptives, which means she can use the oral contraceptive pills, she can use the progesterone-only pills, she can use the injectables, she can use the implants, and she can have an IUD, which means that family history of breast cancer does not actually affect her contraceptive choice. So, and that's contrary to a lot of our beliefs. And a lot of us get worried because if her mother had breast cancer and I've given her the pills, and God forbid she develops breast cancer, then they will blame me. But actually, it's not true, according to the WHO. Now, if we add something else, she has got a fibroadenoma, or she's got a benign breast cyst or fibrocystic disease, where you see a lot of women with fibroadenosis or fibroadenoma, then as you can see, actually, that the same recommendation, that category 1 for everything, she can use everything, even if she's got a fibroadenoma. I've come across a lot of doctors who prevented women from even putting the medicated loop, the levonorgestrel loop, because she's got fibroadenosis or fibroadenoma. So actually, no, you are allowed. You are allowed to use all these methods. It does not affect your condition of fibroadenoma or a benign breast cyst or fibrocystic disease. Now, let's move on to something else. She's got actually breast cancer. And we have to differentiate between somebody who's got a current breast cancer or somebody who's had a past breast cancer with no evidence of current disease for the last 5 years. And this is the only contraindication. We'll avoid all hormonal methods, as you can see. If she's got a current breast cancer, as you can see in the bottom of the this slide there, they're all coming out as 4s, which means they are contraindicated, and only the loop can be used if somebody has got a current breast cancer. Now, if this cancer has been 5 years ago, then all those recommendations move to level 3, which again, we should not be using unless actually that's the only method available. So the recommendation would be with somebody who's had a breast cancer, current, or a breast cancer more than 5 years ago and no evidence of the disease till today, then the best thing for her would be to put a loop. Now let's move on. Second lady, she's a 26-year-old, para 2, coming 40 days after delivery, and she's completed her family. She doesn't want any more children, but cannot be certain. So how would you counsel her? In what order? So I'll again give you just 1 or 2 seconds to think about it. She's para 2, completed her family. She's 40. And she's coming to you because she said, that's it, no more kids. Now, we always start with the long-acting reversible contraception. Reversible because she might change her mind. She's 40. So you can use an IUD and an implant. and they are most effective reversible contraceptive methods. The IUDs, they cause less unscheduled bleeding, they have fewer systemic hormonal side effects, and they have a longer duration of action where you can actually leave the loops for many years. Implants are suitable women who do not want or cannot use an IUD. She doesn't want to use an IUD. It's so difficult for her to insert it, very difficult. Or she doesn't like the idea of having, something in her womb. It's more effective, actually, and more reliable ovulation suppression. A lot of benefits. Less likely to move, less likely to fall out, and if it's been there, she doesn't need to come for regular checkups. Now, the patient has settled on the implant. Do you need any tests? Think about it. Does she really need any tests? And the answer is no. If she's healthy, then nothing needs to be done. No tests are needed, actually. When can she resume intercourse? If she's breastfeeding, then she can go immediately to have intercourse. But if she's not, then it's better to use a backup for 7 days. So just to make sure that the contraception is working, so either avoid intercourse for 7 days or use a backup like condoms for the next 7 days. Now, she told her friend that she's used the implant and she's really happy about it, didn't hurt. And her friend has delivered 3 days prior and she's got to travel. She can't wait for 40 days to apply the loop or the implant and so on. So can it be applied in such a short time after delivery? Have a think about it. What do you think? Can we apply the implant immediately after delivery? And the answer actually is yes, you can. There's no effect on breastfeeding. Looking at the infant milk intake, the rates of exclusive breastfeeding, the newborn weights are completely normal. So it does not interfere with breastfeeding. And it can be offered, before discharge from the hospital after delivery, matching with the WHO recommendations for immediate postpartum use of implants. And sometimes you actually put it in theater. If she's had a vaginal delivery or if she's had a cesarean section, you just take a couple of minutes after she's delivered and you can apply the implant. Now, addressing common misconceptions regarding the hormonal contraceptives. As I said, there's a lot of myths around the use of contraception. So hypertension, women who have a higher systolic blood pressure above 160 or diastolic above 100, what contraception can they use actually? And as you can see, the best option for them would be the copper IUD, or the progesterone-only pills, the implants, the hormonal IUD, they're all fine category 2. We would not recommend the injections, because it's a category 3, and you would not recommend the oral contraceptive pills. What about women who are above 35 and they are heavy smokers? Heavy smokers, by definition, that they smoke more than 15 cigarettes per day. So women who are smoking a pack or 2 packs and they're above 35. As you can see, the best options would be category 1 would be the copper IUD. The progesterone-only pills are fine. The implants, very good. Hormonal IUDs and the injections are fine. And category 4 would be the oral contraceptive pills because you are worried about them developing DVT. Now, looking at women actually who they've developed DVT or pulmonary embolism, and they are already on anticoagulation. So they can use a loop, or they can use implants, they can use progesterone-only pills, hormonal loop, injections, and again, contraindicated to give them contraceptive pills because of the worry about developing clots. Now, major surgery with prolonged immobilization, again, you're worried about the clots, so you'll see category 4, the contraceptive pills, category 1, the copper IUD, and the progesterone-only pills, implants, hormonal IUD, and the injectables are all category 2, which means they're all allowed. Migraines with an aura, okay, migraine with an aura at any age, And the aura is a focal neurological symptom, such as, she gets this flickering lights, or even just getting migraines. Again, she can be on the contraceptive. She can use the progesterone-only pills, the implants, hormonal ID, and the injections are category 2. Best for her actually is the copper IUD. And as regard the contraceptive pills, they are again category 4. So she should not really be on the contraceptive pills. Diabetes with end organ damage. Diabetic women who've got nephropathy, retinopathy, neuropathy, what contraception can we give them? And again, if you look at the different criteria, the best option for them would be the copper IUD. Again, some myths around diabetes and copper IUDs. You can use them because of infection. If the diabetes is well controlled, and it should be actually, then there's no contraindication at all from using a copper IUD. The progesterone-only pills, implants, hormonal ID are all category 2, but it's better not to give them the injections, and it's better not to give them the oral contraceptive pills. Cardiovascular disease, got women with a cardiovascular disease. Again, you'll find that copper IUD is the best option for them. The progesterone-only pills, the implants, and the hormonal ID are not a contraindication with cardiovascular disease, but don't use injections and don't use oral contraceptive pills. Again, unless there's no other method possible. Thank you very much. I hope I've covered all the different points. Thanks a lot.
Thank you very much, Professor Jasser. Very comprehensive, very informative talk. And I think it's very useful for all of us to go through this. It's evidence-based medicine, and it's guide you through the criteria for using different contraceptive methods, and I think it's very useful in day-to-day practice. We will open the now for questions. People can write their questions, and when it comes to the links, I will pass it to Professor Jasser. I will start with the first question, Professor Jasser, from myself. Why do you think there was a drop in the use of contraceptive in the last years compared with 2002? The first slide you present, the first few slides you present.
The use of contraceptive pills. There are a lot of myths around the use of contraceptive pills. Like, for example, in Egypt, people tell you, I do not want anything that messes with my hormones. And there's a strong belief that if you are on the pill and you've not had kids, then this would actually cause infertility. There's a lot of myths around the oral contraceptive pills, the relation to cancer. So I think that's why a lot of women actually, in Egypt especially, they gone off the pill. They do not want to use it, and they prefer other methods that will not mess with their hormones. That's as they plainly put it. I do not want anything that will mess with my hormones. And especially from the husbands as well, they're so worried. And as we said, if there is a family history of cancer, even though they come actually with cancers completely irrelevant, like grandfather had esophageal cancer, so we're worried about using oral contraceptive pills. And so I think the tool from the WHO really useful in convincing women, because if you use it and you show it to the couple and say, well, this is a recommendation from the World Health Organization that actually there is no problem using this method of contraception with your condition, it makes your position stronger because you've got something to back your info. And as we said, at the end of the day, it's an informed choice. So it helps women making their decisions.
Thank you very much, Professor Jasser. I'm sure there's a few questions coming through, but because of we are running short of time, as the session started a bit late, what we will do is we will leave you to go to the chat box and have the questions with Professor Jasser, who will be available for you for the next 10-15 minutes to answer all the questions. And I would like to thank the Professor Jasser for very, very informative talk that is very practical and very useful for everyday practice. Thank you very much, Professor Jasser. And we will conclude this session at this stage, and we'll move to the next session in 1 minute. So keep online. Thank you very much, Professor Jasser.
Thank you very much. Thanks a lot.
But please stay for the chat. Thank you. So welcome back, everyone, again. I will continue to our next session, and as we promised you, we'll have very distinguished speakers with us today. So the next session is going to be about the importance of family planning and pairs spacing, presented by two eminent speakers. The first speaker is going to be Professor Shazia Maqsood, who's a consultant obstetrician and gynecologist, medical administrator, residency training program director in OBG residency training program at Sulaiman Al Habib Medical Group. Dr. Shazia has been the head department of the head of OBGYN in Sulaiman Al Habib for the last 10 years. She's responsible about many of quality and administration work in Sulaiman Al Habib, and she managed to get multiple accreditation to her hospital. She has an extensive education portfolio. She's an recipient of numerous research and training awards. She's an RCOG course organizer and examiner, and has an extensive portfolio in teaching and training for RCOG base exam revision courses and arranging OBGYN simulation training and international OBGYN conferences. Dr. Shazia will start the first talk, and then we will have Professor Azad. Then we will have 10 minutes for questions. Welcome, Dr. Shazia, and it's our pleasure that you are joining us today.
Great, thank you so very much, Dr. Usman, for the detailed introduction. Assalamu alaikum, good afternoon, everybody, and thank you very much for the team to let me be a speaker at the Oscar event. It's so great to be with you today, this morning. What we are going to talk about in the next 15 minutes that's been given to me is about the importance of family planning and birth spacing. Birth spacing, as we all know, is a time interval between one pregnancy and the next. And this is clinically relevant because it may increase the risk for some adverse pregnancies outcomes. The short interval between the pregnancies are more commonly associated with effects than the longer interval, basically. So the degree to which individual pregnancy spacing alters an adverse pregnancy outcome is still unclear. But important is that since they don't have control on such spacing, this could potentially reduce the adverse outcome. A short interpregnancy interval, as we all know, can be intelligently avoided by good education, provision of postpartum contraception, and but we need to understand that becoming pregnant in order to avoid a long interpregnancy interval can be more problematic, since the desired pregnancy may be precluded by factors such as availability for partner, fertility, economic or occupational issues, or even illnesses, chronic illnesses. So today's talk, we will talk about three main issues. We'll talk about what is the optimal interpregnancy interval period between the delivery of the previous infants and conception of the current pregnancy. We will look into the scientific evidence available more recently about the interpregnancy interval. We as healthcare providers in OB/GYN clinics, we have a huge responsibility on us when we are looking after the mothers as a healthcare provider for 9 months. We have got enough time to talk to them about their future pregnancy plans, future family planning plans. And this talk in the 15 minutes, I'll just try to put everything in the stance so that we can have a nice take-home message. We'll also talk about clinical practices. I belong to Saudi Arabia. I've been working in Saudi Arabia for the last 13 years. So we'll talk about clinical practices, what's going on in Saudi Arabia over the last decade as well. So let's talk about the guidelines on the optimal interpregnancy interval and its effect on short interpregnancy interval on mother and child. What does the American College of Gynecology says? What does the Family Planning Association of America says? What does the World Health Organization says about these issues? So here is a distribution of interpregnancy interval following a live birth by country, by state. We talk about USA, we talk about Finland, we talk about Norway, we talk about Western Australia, North-South Australia. So you can see clearly that like about an year, 24 months to 59 months is a more preferable interpregnancy interval in these well-developed countries. And this is proven also by different studies, by different retrospective studies, by different data collection that we are going to discuss in the next few slides. So the Society for Maternal and Fetal Medicine and the American College of Obstetrician and Gynecologists issued an obstetric care consensus for interpregnancy care. And it very goes into very detail, but I just sort of brought a few bullet points for you over here to maximize a woman's level of wellness along her life course. Especially in women with chronic medical conditions, the interpregnancy interval should provide, prolonging an interpregnancy interval should provide an opportunity to optimize the health before a subsequent pregnancy. And this is especially true for diabetic mothers, for hypertensive mothers, for mothers with lupus, and so on and so forth. So education about future health is needed to assist the patient to develop a postpartum care team and making plan for long-term care. So again, mental health, we cannot emphasize more on mental health of the mother immediately after delivery, where there is lack of sleep, looking after maybe one child or maybe two child or more. What about her own vaccination? What about managing her chronic condition? So this obstetric care consensus from coming directly from the ACOG and the Society of Fetal Maternal Medicine emphasizes on all these things. More recently, there was an article back in June this year. It talks about association of interpregnancy interval with adverse birth outcomes. We talk about intrauterine fetal death. We talk about cot deaths. We talk about growth restriction. We talk about worsening of maternal conditions. So this was a Canadian study of nearly 150,000 births, and this was between British Columbia, and it was published in JAMA International Medical Journal. And it says that mothers should wait at least a year between giving birth and getting pregnant, again to reduce the health risk to mother and the baby. And small gaps between pregnancies tends to favor premature birth, small babies, and infant and mother mortality, apart from morbidity. So another article in the Lancet recently, it says association between interpregnancy interval and adverse birth outcome. It again reconfirmed that, and this was a cohort study again from Finland, Norway, and Australia, showing similar results, and they have also advocated an interpregnancy interval of a minimum of 12 months. So all in all, what does the World Health Organization says about it? Well, they have given a consensus about birth spacing, and this is a huge document that came up, and there is a lot of cohort studies and retrospective studies that went into that, and they talk about maternal mortality, preeclampsia, miscarriage, fetal death, stillbirth, preterm birth, small for gestational age, low birth weight, perinatal death, overall neonatal mortality, morbidity, all on a rise, when there is a short interpregnancy interval. So what does the WHO finally conclude? It says after a live birth, the recommended interval before attempting the next pregnancy should at least be 24 months. They're advocating 2 years, because remember, WHO is covering all the countries, including developed as well as underdeveloped countries. So in order to reduce the risk of adverse maternal and perinatal and infant mortalities, WHO advocates 2 years. What about interpregnancy interval in all these data that is available online and from different modalities? They say that women should be advised to avoid interpregnancy interval shorter than 6 months, and counsel about the risk and benefit of interval shorter than 18 months. So there comes your, as a healthcare provider, there comes our responsibility to talk about family planning, to talk about effective and efficient contraception, and emphasizing on maternal health, not only physical health, but also mental health. The second part of my talk today will cover the effect of short interpregnancy interval on mother and child. And in a recent article in September 2022 of this year, in Fertility and Sterility, there was this study published talking about the effect of interpregnancy interval on preterm birth and low birth weight in singleton pregnancies either conceived naturally or with assisted fertilization. And no surprises there. Basically, the outcome, poor preterm, low birth weight, and perinatal death, all adverse pregnancy outcomes were high, and we looked into almost 17,000 births, and so it is very, very clear that reducing the interpregnancy interval about 6 months can be what about the maternal and fetal effects on the baby? Iron deficiency anemia, diabetes and hypertension for the mother, cesarean for the mothers. What about the baby? Growth restriction, preterm labor, intrauterine fetal death, cerebral palsy, neonatal death and SIDS, sudden infant death syndrome. So everything on the high if the interpregnancy interval not taken care of. So in conclusion, an interpregnancy interval of at least 12 months reduces the adverse perinatal outcomes conceived with and without infertility treatment. Short interpregnancy interval is a risk factor for adverse pregnancy outcome. All these cohort and retrospective studies emphasized the importance of providing support for family planning programs, which would support an optimal IPI and improve the pregnancy outcome. The last part of my talk talks about what we are doing in Saudi Arabia, our family planning efforts in Saudi Arabia, and what needs to be done further. I'll start this part of the talk with a recent article published last year in April about awareness and use of family planning methods among women in northern Saudi Arabia. And this was an urban study in the cities. So this study revealed that most women were aware about and had a positive attitude towards family planning. And majority of the participants either used, 2/3 were currently using any contraceptive method, which was higher than the national estimate for Saudi Arabia. However, 1 in 5 were counseled by the healthcare provider for the type of contraceptive method used. 1 in 5. So that's a very low rate. And unfortunately, unavailability of family planning services in primary healthcare center impeded getting professional counseling. So it is imperious to consider family planning clinics to provide quality family planning services. That's the consensus in Saudi Arabia at the moment. And the Vision 2030 is working towards it. So this was the awareness that, like this slide shows the awareness and the use of family planning methods in the women in northern Saudi Arabia. 67% followed what their family and friends and their aunts and mothers were doing. 50% went to the doctor and followed the doctor advice, and between 34 and 43% used the internet and social media to help getting family planning advice. So again, a lot needs to be said and done in terms of establishing family planning clinics in Saudi Arabia as such. Again, pill was the commonest choice among these women, followed by withdrawal, and then IUCD, then hormonal patches and condoms and so on. So what needs to be done further in Saudi Arabia is 1 in 5 got counseling for the contraceptive method, and 40% of the last births were unplanned in Saudi Arabia. So a huge room for family planning services, family planning guidance, family planning counseling. Almost all women reported unavailable family planning clinics in their primary healthcare centers, and most women were aware about and had a positive attitude towards family planning. Means that, if talked into using appropriate family planning method, the acceptance and the compliance rate would be high. The take-home message is, number 1, shorter IPIs are associated with increased risk of adverse pregnancy outcome. 2, healthcare providers should identify and counsel women who have recently given birth regarding the effects of IPI. And 3, all data emphasizes upon the importance of providing support for planning services. I'm going to end my talk by giving you 2 small, simple questions of poll, and I'm sure somebody from the IT would help us running this poll for us. So it's poll time. Question number 1, what is an ideal IPI following a case of uterine scar rupture? Is it 1 year? Is it 2 year? Or is it 3 year? Can somebody from the IT help me, please?
Dr. Shazia, if the audience can go to their networking lounge, and then they can answer this for you, because we are running short of time, I'll be grateful. So sure. This is a poll, sure. And then you can receive that in the networking lounge.
Perfect. We'll do next time. Yes. So thank you so.
And the next question, what is the next one?
The next one is, what is an ideal interpregnancy interval after 3 recurrent early pregnancy losses? One is, what is the ideal IPI following a case of uterine scar rupture? And And next is of 3 recurrent early pregnancy losses.
Excellent. So we'll leave the audience to answer that in the networking lounge, and then you can have 10-minute discussion with them after the question and answer time.
Great. Thank you.
So thank you very much, Dr. Shazia. Very informative talk, very relevant, and most importantly, you got data from the Saudi Arabia, which is very relevant to the region. Because of time constraint, we straight move to Professor Azad Khosroni. He's the head of Obstetric and Gynecology Department at St. Joseph University Hospital in Montreal, and he has a Welsh experience with more than 40 peer-reviewed publications and an extensive experience of obstetric and gynecology and family planning and contraception. So, Professor Azad, the floor is yours.
Thank you so much. Thank you, Dr. Shazia. Your presentation is very clear, and I'm sure it will help me also to make my presentation even more clear. So, we'll be talking about 4 topics. We will talk about long interpregnancy interval. We'll be talking about family planning programs in Lebanon and in Jordan and how they improve birth spacing. We're going to talk also about global efforts to improve family planning, as stated by the United Nations, and what can we do to make things better, how to improve family planning programs. So we start with a small quiz with a small poll. Also, we could answer it in the lounges after that. So long interpregnancy interval is characterized by which of these items best? If you want to choose one, is it better perinatal outcome, worse perinatal outcome, same perinatal outcome, better maternal outcome, or worse maternal outcome? So I'll leave it to you. After listening to the talk, maybe we'll have more glitch about it. So the effect of long interpregnancy interval on mother and child have been less studied. We have one nice review article, the one by Conde and Agudelo in 2006, and there is also, after that, many papers that have come out about this issue. But the most talk about is short intervals. Long intervals, particularly more than 60 months, are less studied. So we have fewer data to talk about it, but we're going to explore this issue. We have the study in 2008 from Bangladesh that talks mostly about shorter intervals and a little bit about longer intervals. This is about demographic and health surveys, which have a huge number of population, of studied population, where they also talk about the risk of mortality, which is the highest for very short intervals. But they also are prone, they also talk about long intervals in a few sections. And we have also that this one in maternal and child nutrition in 2007. They talk about child nutrition studies with longer birth intervals are associated with a lower risk of malnutrition in some population, but not all of the populations studied. This one's more recent, and this is the Swedish. So we have another type of population that is studied, and this Swedish study find really less effects on the outcomes. Mainly when we talk about long interval, 60 months, the effect that they found is not really much significant. So they have a few differences in the patterns by maternal education level or maternal country, but all in all, we don't have this considerable effect. The study is published in 2020. It's, the population study is mainly Chinese, and we have 2 adverse outcomes that are reported for IPI more than 120 months. And these are gestational diabetes and the premature rupture of membranes. The study is published really recently in 2022 in JAMA New Open, Network Open. And we have also a big population study in China also. And in this study, we have an association with preterm birth and low birth weight that are studied. There are critics for this study, mainly because it's based on comparison of siblings mostly. But it also shows us that long intervals are associated with adverse outcome in the studies. This last article comes from Tanzania in 2016, where they say that both short and long IPI are independent risk factors for adverse pregnancy outcomes. And when we have it really long, we have higher risk of preterm birth and low birth weight, but not with perinatal death. So we see that what is recommended to wait, the WHO said that we should have an optimal interval of about 2 years. We should also avoid long intervals because they are associated with perinatal adverse outcome. So the second part of my talk is family planning in Lebanon and Jordan. And I must say that I'm more comfortable of talking about Lebanon because it's my country. The programs here are mainly through the Ministry of Health or independent NGOs, sometimes in partnership in both. And it addresses more the rural area and the cities. And some of them address particularly the refugees program. As you know, we have a big part of the population is from Syrian refugees years ago. So this data comes from the Vital Data Observatory dashboard, which year after year gives us data about births in Lebanon. So this comes from 2021. We see that every 5 minutes we have a baby that is born. But what is really particular here, we see that practically 55% of these babies are Lebanese. And many of these babies that are born are not Lebanese. They come from refugees camps. So if you want to target family planning, we should also target the refugees, and we should also target plans and family planning in these areas also. This is an older data in 2018, where we look particularly at the teenage deliveries. And this is, again, worrisome because we see about 9% of all deliveries in Lebanon were teenage deliveries. And this is a matter of concern, of course. And if we look here, we see that the Syrian refugees represent almost 3/4 of this number. So this could be an area where we have room to improve and to make family planning really a target to be achieved. So there are many NGOs that work for this family planning in Lebanon and Jordan. In Lebanon, we have the Lebanon Family Planning Association that has many activities. One of these activities is to promote healthy birth and also family planning. Another institution is the one guided by the UN, where we have the Population Fund, the UN Population Fund. And it has many activities in Lebanon. One of these is by an association that's called Salama, which has opened particularly some clinic in rural areas to promote health and family planning. Publications, we have some publications. This comes from 2019. Very briefly, to say that despite favorable knowledge, access to family planning methods, and positive attitudes, there is, however, a clear stagnation in the rate of contraceptive use over the past 4 decades. The impact could be due to religion, age, and sometimes lower educational levels. And this is published in 2019. We should also state that during the last 3 years, we have really huge financial crisis in the country. And it also hit the family planning, where we have this comes from a newspaper in Lebanon, where they say that birth control become unaffordable, and of course abortion is illegal. So people are confronted with much problems here, and this comes from December 2021. Another publication also in November 2021. So people are starting to look at family planning as one of the aspects of their daily economic crisis, in fact. But another country, another view, this is Jordan. I'll try to talk as much as I know. So we have a family health survey that is that was published for 2017-2018, and very briefly, where we have the distribution of women and men according to nationalities, and these are the methods that are used. So modern method represents 37%, IUD 21, the pill 8, the condom 5. So this gives us a representation of what contraception is used in Jordan for the time. Also, the fertility from 1990 to 2017 have decreased in this country also. There's one publication that is published rather recently, where they talk mostly about the role of the husband. The husband seems to have an influential role and perhaps the final say in deciding whether to use family planning or not. And this also could be taken into account when we are promoting some kind of family planning or policy in a country. The third part of my talk, and this is really important, is the UN Sustainable Development Goals. I'll just read it as it is. So it calls on countries by 2030 to ensure universal access to sexual and reproductive healthcare services, including for family planning, information and education, and the integration of reproductive health into national strategies and programs. And this is important because this is a goal that we should attain, all countries should attain. So why is it really important for young women? Investing in family planning has long-term positive impact on the health, lives, and prospects of women and girls, alongside significant benefits for the whole society. So if we have a lack of access to adequate contraceptive methods, young women, particularly adolescent women or teen women, are twice as likely to die from pregnancy-related complications if they give birth under the age of 20 years. And of course, we have the other perinatal adverse outcome as shown before. So if we don't have really good contraception, the other alternative could be abortion, and this is particularly dangerous in low-income countries. Also, girls that have early children are more likely to drop out of education, which means lack of opportunities for them. They also represent then a financial burden, and we have plenty of social issues that comes after that. So the last part is, how can we better improve the family planning programs? Of course, by having a performing family planning centers. To have better access, it is useless to have a family planning center and so far away from people to reach it. The funding is also important. We need also to optimize contraception according to each need and each situation. So it's rather a patient-tailored contraception that we should have. So counseling is important. And most of all, the most important of all is education, is talking to people, emphasizing the importance of family planning for their lives. Another important point is to target the critical period, which is the postpartum. So we have many publications from many countries. Just to go rapidly over it, this is from Peru and from Indonesia, and they say that 10% of pregnancies occur before menses resumed. So we should really, at this point, talk a lot about family planning for breastfeeding women. This comes from Egypt, 2008. 29% of pregnancies happened during breastfeeding and were unintended. So this is a good area to talk about it. Also, in Guinea-Bissau, weaning due to new pregnancy is associated with higher mortality from the elder child, because the elder child had less nutritional help at this point. So this is the whole presentation. I hope I can answer your questions. The aim of it is to achieve harmony and family planning benefits for the societies. Thank you.
Thank you very much, Professor Azad. It's for the very informative talk and very wealthy talk from you and from Dr. Shazia. I'm sure there's a few questions, a lot of questions will come through. So I will start with a question, probably is for both of you. Someone from Egypt is asking about, it's a comment, I think, rather than a question. I see it will be very helpful for Egypt to go through family planning in putting this implant post-delivery for free, and to help women to get their oral contraceptive pills for free from family planning, and then stress about the education and awareness. So do you think that's insertion of Implanon after delivery is the best timing for the Implanon?
Absolutely. Absolutely. I would second that. That's something that, because my background is from UK and Ireland, and that's something that we have been doing it for the last 2 decades, especially for teenage pregnancies. They get their Implanon inserted in the hospital before discharge from the hospital. And the family planning clinics provide, as you know, in the UK and in Ireland, family planning clinic provide free contraception, including the Implanon. So there you see a great, appreciation of education of the girl child, a great appreciation of career orientation, etc. I mean, there's a fine balance between the two modalities that the undergrowth countries and the well-developed countries suffer from. But yes, I would second the thought from the doctor who has commented that definitely we need free family planning services, including long-acting reversible contraceptives like Implanon implant. Yes.
Yeah, yes, indeed. I'll second that. Yes, I think this is a good opportunity to offer adequate contraception for these ladies. Absolutely.
And I will go for this. I think the question. This the question about that you raised in the first both of you about the optimum interval, pregnancy interval, in a normal situation and in certain specific situation where patient has cesarean section. This is a common scenario, or after a uterine rupture or after myomectomy. So you are both experts, so if you can provide your expert advice on that.
Okay, would Dr. Assad want to shall I?
No, it's your question, it's your answer, of course.
Okay. All right. So as you know, as per the slides that we shared with you all, an interpregnancy interval of a minimum of 1 year is required for any previous history of normal pregnancies, and the WHO, as you know, is advocating now 2 years. Now, when it comes to uterine rupture, obviously it would make a lot of sense if we counsel the lady to at least delay the pregnancy for 2, if not 3 years. And same goes for myomectomy, 2 years at least. And then the same scenario that we were talking about, which is recurrent pregnancy loss, 3 pregnancy loss, which is consecutive according to the definition. There is a lot to be said in that, like what could be an optimal interpregnancy interval, because over here you are trying to investigate whether she has PCOS, you are trying to investigate whether she has any thrombophilias, any hereditary thrombophilias, you're trying to investigate if she has any uterine problems, intrauterine, synecdoche or septum, etc. And on top of everything, what about her mental health? What about the couple's mental health, emotional duress, emotional distress? If it happens again, would she be ready for that? So again, I think simply the answer to that would be a minimum of 6 months, so that all the investigations are complete, so that we have addressed the mental health of the couple as well before they embark either on trying to conceive naturally, or they want to take help with fertility services to conceive with IVF. Thank you.
Thank you very much. Professor Assad, what is the best contraceptive message for women with polycystic ovaries?
Well, I think there are many contraceptive methods that we can use for these ladies. The pill is one choice, the implant is another choice. Once again, I think we should seek patient-tailored contraception, because this is the most important. We should talk to people, we should tell her about the benefits and the risk of every method. So I look at it more as a holistic consultation at that point, with the polycystic ovary being one of the items. And I look further at what her complaints. So if she has a complaint of acne and a need for contraception, I think the pill would be really inadequate for her. If she seeks long-term contraception, then the implant would be a nice contraception for her. That would be my answer, really.
Okay.
But I would like to, if you allow me, I would like to ask Dr. Shazia about the interval of after a rupture of 2 years and 3 years. Do you think that there is much difference between 2 and 3 years? If we talk numbers, do you think it really makes a difference if we wait 3 rather than 2 years? Of course, there is a difference if we wait 6 months than 6 months or 2 years. But between 2 or 3, do you think there is much difference?
Yeah, over here the peers talk about an overall clinical picture. What is the BMI? What was the nature of the rupture, etc. You know, so if the overall clinical picture favors 3 years, the more the merrier. But a minimum of 2 years. That's what the consensus is saying. A minimum of 2 years, not less than that, would be required. 3 would be ideal. 4 or 5 would be ideal, as a matter of fact. But having said that, the overall clinical picture of what was the nature of rupture, what was the outcome of the pregnancy, again, what is the medical health of the mother, what is the BMI of the mother, and what's her family like. So all of these things will depend on the decision making again. But yes, a minimum of 2 years. Ideally, yes, 3 years.
And 2 questions about Implanon. The first question is which one is more painful, Implanon insertion or IUD insertion? The second question is about is Implanon is legal to be inserted in teens under 18 years old? One question for Dr. Shazia. The first question, which one is more painful? And then the other question is for Dr. Azad about the age.
Please choose.
Yeah, I smirk because, IUCD insertion, you have to counsel the lady about, we'll be pinching the cervix, there will be a bit of pain, you have to come during your periods, and we will put in the IUCD, and that will be painful. And we give you some painkillers, and sometime if you are having infection, we have to give you antibiotics as well. So all this is, null and voided when you're talking about an Implanon. And yes, it's hardly painful at all. Like, I've been inserting Implanon since the early 2000s, and pain has never been an issue with an Implanon, albeit you do give a bit of local anesthesia while insertion and removal of Implanon, but again, pain has never been an issue. So obviously my first choice, if you're talking about pain, would be an Implanon LARC. Yeah.
Thank you very much. And legality of teenager?
Well, yes, I also say that the pain is not really an issue. We have really people that are happy within the insertion process. I would like to just say about people who are less than 18 years old. We haven't talked a lot about the legal issues, because people who have less than 18, we have to also take the consent of the parents. I think this is the legal. I don't know if this is common in all countries, but in my country, we should take the consent of the parents below 18 years.
I can tell about the UK and Ireland that, the law of Gillick competence prevails in those countries and Scandinavian countries. So if the person who comes for family planning, even if she's 13-year-old or 14-year-old, and if the healthcare provider deems that she is intelligent enough to understand the risk and the benefits of the Implanon, then yes. And as I said earlier, that, it is usually a routine, especially for teenage pregnancies, while they're in the hospitals to fit in an implant before they go home. So it really, it's like a cultural debate. It will open a Pandora box of a cultural debate, if Dr. Assad will agree with me, that, every country is different, and where we are practicing at the moment, so obviously parental consent goes hand in hand with, like even a husband's consent goes hand in hand with whatever contraceptive choices the woman is making. So yes, it really depends on where we are practicing.
Excellent. So, and a last question, I think it's an advice from how do you manage the spotting continuous bleeding after insertion of implant in the first 3 months? Because this is a commonest reason for removal of implant.
Yeah. Oh, absolutely. Like the first thing is counseling. First thing is, if I, as a healthcare provider, am confident about what I am telling my patient or my client, then she will be taking an uptake seriously. That, this is a long-acting reversible contraceptive, and anything long-acting will either affect your periods either way. Either you'll have an irregular bleeding, or you may not have any periods at all, or it may be intermittent spotting. So where we are in the Gulf countries, obviously Ramadan and fasting and praying is a big issue, and the issue with the religious issue with hez and nafas is an issue. So we talk to them about that. I normally tell them that we can give an add-back therapy if they are having any irregular spotting for that, and there should not be a reason to remove it. Especially the first question that you need to ask the client is, how badly do you not want to get pregnant in the next 3 years' time? And that is the real answer. Then if you are okay, if you're happy to be, only in the next few months we'll be able to tell what period pattern your body will say. So I would normally see them in about a month's time or 2 months' time that they have kept a periods diary. About like two out of 10 would come back without an appointment and would be addressing the periods issue. And most of the time, 9 out of the 10 time, they need reassurance, and maybe 1 out of 10 will need an add-back therapy for a couple of months, couple of cycles, so that things settle down. Again, giving a written information leaflet is very important when you're fitting in an implant on, or even before fitting in an implant on, to sit down and read about it, so that they are very clear that they do not say on the second visit that I will not explain that. So counseling.
Thank you very much. Very last question, Prof. Azad. When we can insert IUCD after C-section?
After implant, do you mean?
No, IUCD, coil.
The coil. In some countries, they even insert it during the C-section. In most of the patients, we usually see her at the postpartum visit, where we can do it. But from the time of when she have her leaving the hospital till the postpartum visit, we need to have an adequate contraception, so not to have accidents, mainly for people who are not breastfeeding. But usually we do that at the postpartum visit.
Yeah. Okay. So thank you very much. We're just on time now. We'll leave the rest of the question. If you can join the speakers on the networking lounge, then you can have more chat with the speakers. Thank you very much, Professor Azad. Thank you very much.
Thank you,
Dr. Shazia, for the very nice session and for the very nice discussion. It's been a pleasure having you here. Thank you very much.
Thank you, Dr. Usman.
And for the audience, we will move to the next session in 1 minute. Hi, everyone, again. Welcome again to our third and last session. And we are honored to have one of international experts on contraception, Professor Johannes Pitzer from Switzerland. He works in University Hospital Basel, Switzerland. He's past editor-in-chief of European Journal of Contraception and Reproductive Health Care, and past president of the European Society of Contraception and Reproductive Health Care. Professor Pitzer is going to talk to us about good practice in contraceptive counseling, which is a science and art, which is an important skill, and actually the most important skills for providing contraceptive services. So the floor is yours, Professor.
Thank you very much. I'm going to share my screen. And first of all, thank you for the invitation. It's one of my favorite subjects. I like to talk about this issue of contraceptive counseling, and I hope we can exchange some of our ideas. These are the declarations of interest. Basically, when we look at in the consultation, when it comes to contraception, the two partners have sort of different interests also. The healthcare professional, we want to maximize efficacy, we want to minimize health risks, we want to optimize tolerability, and we want to realize additional health benefits. And ideally, we want also to be in a cost-benefit relation there. On the patient side, of course, women and also men share the same basic four objectives. They want to have maximal efficacy, they want to have minimal health risks, they want to have optimal tolerability, they want to have additional health benefits, but they have an individual profile. They may have other wishes and other needs. Should it be independent of the partner? Should it be under the control of the woman? Should it be easy to use, not forgettable? Should it be linked to sexual activity? Should it be on demand, etc.? So besides the classical four objectives, we have others which are very individual, and at the same time also the tolerability is very individual, and additional health benefits are a very individual issue. So it is really an art, you know, to bring these two variables, or I will tell you it's about three variables actually, to bring them together because we have a lot of methods and we have even many more women, and now to find among these methods the right method for the individual woman, and that is what we call contraceptive counseling. We have looked into that more from a scientific point of view and found that the objective is that you make three variables fit optimal together: the method profile, the woman's profile, and the context. And I would like to talk about this with you now. Now, the variable one, the method. As I mentioned before, I think each method has to be understood from these four perspectives: efficacy, effectiveness, health risks, side effects, quality of life, and health protection and benefit. These are the four dimensions which we have to understand and know about as medical professionals for all these methods that are available. So this is, I would say, the scientific background and our training and our knowledge. The variable two is the woman herself. Now, the woman, there are sort of two aspects. One is the subjective part. What are her contraceptive needs, her values, her wishes, her health beliefs, her concerns and fears? What is her experience? And then the objective part, which is, the medical profile, classically the diseases, drugs, risks, symptoms, but also behavioral risks, stresses, mental and sexual health issues, and in general other symptoms that may impair her quality of life. And finally, the variable 3, which has an impact on the contraceptive counseling and contraceptive decision making. It's the life condition, the life phase, is the socio-economic environment, the health system, the culture, the health beliefs, the sexual rights, the accessibility of services, the availability of methods, the training of providers. All these factors also finally co-determine the final decision and the final use of methods. Now, how can we make this best fit? On one hand, the methods, on the other hand, the woman. I think, as I mentioned before, there are these on our medical professional side. We need this professional competence, needing a lot of knowledge, but we need also communication competence to bring these 3 variables optimal together. I've put it here on this slide that we somehow have these 3 dimensions. We have the woman with her expectations, her fear, her values. What do I want? What do I need in my present situation? What are my fears and concerns? What are my health beliefs? What do I know? My questions. So this subjective part, we have her medical profile with the risks and symptoms and complaints, the diagnosis, the clinical conditions, and we have her context, her life context, with all the stresses, the life phase, the relationship. And then we have these methods available. Look here at the right side. And what I'm trying to show you now is how can we tailor contraception? How can we bring these variables together? And we have developed sort of a structured interview or a structured dialogue, which would respect the different aspects of patient-centered communication, information and education, and shared decision-making, what we call the contraceptive dialogue. Now, what is the first step? The woman comes into your consultation, and I think the first step is really to listen actively and understand the needs. What is her situation? What does she want? What does she need? This listening is quite important because it includes to understand her subjective needs, her profile, her concerns, her beliefs, because it is quite important that we respect the values and beliefs and that we understand her experience and her also knowledge or gaps of knowledge. So let's go through this case. There is this 21-year-old nulli gravida, recently married. She has a 100% job in a tech startup business. Her husband is an official in a large bank. She does not want to get pregnant because she's still in a training program for her job, which she likes very much and which offers her interesting career possibilities. Her job is very stressful and demanding. She needs very effective contraception with low risk of forgetting. Her main concern is her fear of breast cancer and therefore the fear of what hormones can do also to her sexual life. So here we are with our picture, and if we look now at her subjective part, at her expectations, she wants highly effective, low risk of missing, making a failure, fear of breast cancer, certain concerns about hormones and sexuality. And by listening to her, we can sort of not completely exclude, but put aside a little bit specific methods here. Like we wouldn't talk really about barrier methods and NFP because she needs in her situation a very effective method. we would maybe have a yellow light more on these short-acting methods, and we would have a certain green light for the large, for the LNG IUD, for the ethanoorchestrate implant, and the copper IUD. At least to keep that in our, mind. Now, the second step, after having listened, after having understood her individual situation, is that what you always do, you determine the biopsychosocial profile. What is the medical conditions? What are the symptoms? We do that to exclude methods which are not applicable based on the eligibility criteria, as you know. So the first step, we would more exclude those methods which do not fit in the need profile. And the second step would to exclude methods which would not fit into eligibility criteria. At the same time, it's all an ongoing educational information process. Now, if you look at these medical issues, her menarche, she was 14 years old. She reports irregular bleeding, sometimes heavy bleeding with dysmenorrhea. The aunt was diagnosed with breast cancer premenopausally. When she is in stress, she smokes up to 20 cigarettes. Her BMI is 27. She has a sedentary lifestyle, no sports, family history, father, myocardial infarction at age 52, mother diabetes. The sister of mother, as I mentioned before, with a breast cancer premenopausally. Now, what are we going to do with these information? We are looking into the different guidelines, either the UK or the WHO or your national guidelines, to see whether the available methods would be contraindicated, would have a category 3 or 4 for this patient. And you know, this is very helpful. This is an example of what the faculty provides us with. If you know, for example, for progestogen-based contraception, short and long-term, similarities and differences, where we can see that in some conditions you should not continue. You may initiate, but you should not continue with the method, or the method is clearly contraindicated. So I think you all know about these eligibility criteria, which are in fact very helpful for all of us. So if we take these issues of the medical profile, in this step we would exclude methods the women should not use for medical reasons. And here, for example, we would probably be rather reluctant with combined hormone contraceptives, with a lifestyle, with a smoking. It wouldn't be an absolute contraindication, but we would rather move it towards red. The progestogen-only contraception would still be yellow, but it's more short-acting, and our long-acting methods would remain green because they don't present a risk to the patient. They don't present any health risks and could be then used. Now, we have gone through this second step, and we have looked into the biopsychosocial profile again to see, and this is the third step, among those methods which the woman can use, which fit to the needs, which fits to the eligibility, are there methods that would have an additional benefit that could help her to stay with the method and to improve adherence and compliance? And that would be then the step to choose the method together with the patient. Now, looking for additional benefits, let's go back to our case. Menarche, 14 years. And I think what we could really look into irregular bleeding, sometimes heavy bleeding with dysmenorrhea. Among those methods which are left, are there methods that would help her with this? And as you can see, this is our knowledge where we can look for different aspects. Would the patient need, has she a risk of osteoporosis? No. Is there anemia? No. Is there PCO? No. But we see that there is this irregular heavy bleeding and dysmenorrhea, and that our methods, which are left, which are the LARCs, would act positively on this, and would give, in this sense, an additional benefit. So this is our sort of third step, that among the methods that are left, we would look for a method with additional benefits, and here it is indeed the two progestogen-based LARCs, because actually the copper IUD, of course, in a patient with dysmenorrhea with intermittent heavy bleeding would not be the good option, although it would not be basically contraindicated. So here we are then. We have, together with the patient, gone through these different steps of discussion, and then we would finally choose the method together with her, looking for the personal preferences. Is she more for uterine contraception? Is she more for transdermal long-acting contraception? And this part is very important because it's about information and education. It's about helping the user to understand decision-making. This is what we call tailored contraception. What does it mean to inform and educate about the method? We should really help the patient to understand the efficacy, the health risks, the tolerability, the benefits, and there are techniques which we know since many years, that it's called the elicit, provide, elicit principle, that you elicit the needs, the knowledge, the expectations, the experience you provide, and that's very important, small units of information, giving a good structure and summarizing. For example, saying, now that is very important, what I would like to tell you now, which is, you know, the risk is about 2 in 10,000, and I'm coming back to this in a minute. And then to elicit the understanding, is it okay? Are there questions coming up? What does this information mean to you? Are there any concerns? So for this part of our consultation, of course, we need a lot of knowledge. This is, we need knowledge about the guidelines, we need the knowledge about the newest studies, we need our clinical experience, and this is what is called evidence-based medicine. The important part in this is the counseling about risks, and that means understand statistics, specify verbal risk descriptions with numbers, low, high, describe absolute risks in well-defined background population. If possible, compare it to everyday risk and visualize everyday risk and absolute risk. And what is very important, it's outcome, not only 2 in 10,000, but 9,998 will not have this complication. This is the famous visualization in this case for combined hormonal contraceptives, where you can see with a background of 10,000 users what the individual risk is. And this is then what we call shared decision making. Here again, the example of the combined hormonal contraceptive, but you can put all different methods in. You look at the benefits, at the proven benefits from the literature, from the guidelines. You look at the risks and side effects. That is the part of the medical professional in the consultation. He or she provides evidence-based information, but it is very important that the woman gives way to these evidence-based information. What is important for her? What are her priorities, so that she can balance between the pros and cons? And there are always pros and cons, and there is always a certain trade-off, of course. In the follow-up visit, I think it is important to look into satisfaction. Did she reach the aims she wanted to reach? Were there any health problems? How was the tolerability? What was her experience with the practice of use? And I think if this evaluation is positive, she will go on with the method and we will have sort of a stable method use. If there are problems, you would go back and look into other alternatives, again, according a little bit to the guideline I mentioned before. So in summary, I think women and men have the right to have access to available contraceptive methods, good contraceptive counseling and care. Contraception is for many women a long-term preventive behavior for decades, for example. The success of preventing unwanted pregnancies in each individual depends on the method, the user, and the environment, what we call the contraceptive triangle. The role of the healthcare professional is to help the individual woman to find and choose the method which best responds to her needs and her biopsychosocial profile, as we have tried to go through with this case. There is this structured approach going through different steps. Listen to the needs and exclude methods the woman does not want or does not fit to her need profile. Assess the biopsychosocial profile to exclude methods the woman should not use, either for medical reasons, but also, for example, for cultural reasons, having a certain impact on the menstrual cycle which would not be accepted. And then look for methods which may have additional benefits. There may be some left, and inform and educate about these methods so that you can come to a shared decision with the individual woman. Thank you very much for your attention. I hope I could give you some stimulation about this important issue of contraceptive counseling in my view. Thank you very much.
Thank you very much, Professor. Very, very rich. Honestly, it's one of the very nice lecture that I have attended on contraception. I think it's very useful for everyone. Especially, I think contraceptive training is lagging in a lot of curriculum in training for most of the doctors from medical schools throughout the different specialties. I will wait for questions from the audience, but I will start from questions from my side. I think from what you have said, the main gap in counseling women for contraceptive methods is the subjective part, where we all are aware about indication, contraindication of different methods, but we don't go into dig and speak to the woman about it.
Right.
So how do you think that's how we can train our juniors, our trainees on going on that part, speaking to women and elicit a structural approach to this?
Right, right. I think it is really quite helpful to start the consultation, or when the woman comes for the first time, saying, you come for contraception. I think it is important for me to understand what your needs are, what your family planning needs are. How do you plan your family? How long would you now want to have a protection against an unwanted pregnancy? What would you expect from the methods? Do you know already something about methods? What are your concerns? So you try to understand a little bit her individual profile, in the sense, what is her experience? What are her expectations? What, for example, does she not want right from the beginning? So to indicate, well, this is something important for you. You must find the best. It is important that you find the best method for you, because it is such an important issue to protect you against unwanted pregnancies, so that you invite her to get into this dialogue instead of sort of starting with history taking, and you are the expert and you apply eligibility criteria. And because I often say to my students or residents, you know, from a purely medical point of view, it is quite clear that the best contraceptive methods are the lungs, and they are very effective, and they have very low health risks. So, from a medical point of view, we could, you know, sort of say no need for counseling, because that is what women should use. Now, this tendency was here for a while also in the US, and then suddenly people realized that this is unethical. It is a sort of a contraceptive coercion, it was called, and there was even a movement against contraceptive coercion, because people said it's up to the woman to decide, and she must have options which are not purely medical. They need, because it's a long-term project, it has to do with quality of life, it has to do with integration into life, it has to do with personal preferences. So this is why I think this part of collecting this sort of first information gives the patient or the woman a good, in our experience, it gives the woman a good feeling that she's an individual. She's really respected with her concerns and her wishes.
Thank you very much.
And it doesn't take, if I may say very briefly, it doesn't take too much time, because that's always the argument. We have only 5. I mean, a first contraceptive counseling session, when it really comes with a decision which method, 5 minutes is too short, to be honest. But I think in 10 minutes you can do quite a structured interview.
There's some few questions about different contraceptive methods. If you don't mind, can you take these questions?
Yes.
Can you take this? Okay, so the first question is, can a woman freeze her eggs if she's on hormonal long-acting reversal contraceptive?
I didn't understand the first part of the question, sorry.
Can a woman freeze her eggs if she's on long-term contraceptives, hormonal contraceptive, like implant or Mirena or some long-term contraceptive method?
To freeze the eggs while she is on the contraceptive method. Is that what
if she's considering to get pregnant in the future, but now, while using a long-term contraceptive method, can they do the freezing? For example, if the implant is still on, are they still able to?
Regarding my fertility colleagues, they would not appreciate that to do the freezing under this type of contraception. It is more about, the concern in freezing is, of course, to have sort of good egg cells, high quality egg cells. We don't know exactly what happens on that level during LARC treatment. But on the other hand, there are people, I think that the question is not completely resolved. There are units and experts who say it's not a problem because the ovarian function itself is regarding the rights are not impaired. But I think it is probably really difficult to do stimulation because you want to do stimulation to obtain egg cells while using, for example, something which probably fertility experts would not want to do. In summary, I'd say no, don't do it.
Okay. And the next question, thank you very much. The next question is why the IFRA patches is not applicable for women above the age of 35?
Excuse me. You're talking about the contraceptive patch with the ethinyl estradiol, and I am not aware of any international guideline that would indicate that the age alone, like being older than 35, would be a contraindication against all types of hormonal contraceptives. So I don't know.
I do agree. Honestly, I didn't understand the question. So I thought I'd just pass it to you, but I fully agree. There's no age limit to the patches.
Right. If you don't have additional risk factors. Yeah. Mm-hmm.
That's right. And another question or comments is counseling should be done for both couple, or you prefer this? If a woman want to come and ask about contraceptives,
yes,
best contraceptive method, is it best to get the partner as well, counsel them as a couple, or just counsel the woman?
Well, ideally, I believe in many cultures it would be the best to have both. I'm very much in favor of that, but it's, of course, first of all, it's the woman's decision because it's her body and it's her. We're talking about something which has consequences for her. But if she would agree, I think regarding tolerability, regarding the compliance, regarding the adherence with a specific method, and also regarding the joint responsibility for reproductive decisions, family planning, etc. This would be the if I may say, the ideal situation. Sorry.
And another question is just about in our culture, in the region here, lots of time the woman will come to you and I'll tell you that's what's the best contraceptive method for me. Okay. You are a doctor, you know better, so choose for me. Okay. What do you do with such situation?
Yeah, I think this is what we call the situation of directive counseling. If you get the direct, how do you say, the direct invitation or the direct, in German is called Auftrag, the task. And if the patient says, I want you to decide for me, you can say, to a certain degree, I can do that. I can look at the risk factors and I can show you which methods would be available regarding your risk factors. But the final decision I cannot make for you because like you have 4 possible methods which you can use. How should I know which one of those corresponds best to your needs and what you want? Yeah, it's a little bit like you wouldn't go to buy a car and say, to the car seller, you tell me which car
okay, I agree. And a last question, probably, would you advise audience for if they want to learn more about counseling, do you have any resources or education and materials on counseling that you direct them to that platform?
Yeah, until now we don't have a platform, but we are in the process of creating what we, and I mean with we, I mean European Board and College of Obstetrics and Gynecology together with the European Society of Contraception. We are right now developing a curriculum and training program and also an exam on sexual and reproductive health care. Abortion care for those countries where it's possible, and sexual health care. And in that context, we would also produce interviews and material. Until now, for example, what I've tried to summarize in my talk today was a little bit what we have described in the European Journal of Contraception as this stepwise approach. But I think in the future we will provide more material in a structured way, and we invite, of course, all interested people to participate in the curriculum, and also if they want to join in for the fellowship exam.
Okay, thank you very much. There's two quick questions. One of the questions probably might not be very relevant to you because it's about the practice in Saudi Arabia. The question about handling patient wants long-term contraception, but their husband against it. They are afraid the husband will discover it. So obviously, if you practice in any other country, you counsel the woman. This is her right of choosing what she wants. And I think it's apply even in the region. You always counsel the woman. It's her job to speak to her husband, and you don't get into
I understand.
that.
You know, this is something about in some of our consultations we ethical issue. You know, and then I think it is okay for the doctor to say, look, these are my ethical principles. One of my important principles is respect for autonomy. And this means that I have to really respond to your needs and to make it clear that this is something that is the frame of our work. Yeah.
The very last question before we conclude the session, it's which more side effect after implanting amenorrhea or breakthrough bleeding?
Very good question. There are contradictory studies on that. Interesting enough, in Switzerland, they have done a small study. We did have really a problem of irregular and partially heavy bleeding as a main reason for discontinuation. Diana Mansour and others in the UK had different experiences. We have tried to do a study to see if, for example, before using the implanon or the Nexplanon, if it would be helpful, like a 3 months treatment with Cerazette, to see whether this would predict the bleeding pattern under the implant, but it didn't turn out to be very predictive. So this is something which we still, in my view, haven't quite resolved. We cannot counsel or give the individual patient a prediction. We just can say this is, it looks like about 10 to 15% have bleeding problems, which would impair their tolerability and which would lead to discontinuation, or to the need of finding a solution, which, as you know, is not yet a clear-cut guideline what you should do with these prolonged bleeding under implant.
Thank you very much, Professor. We are going to conclude the session here now. There's further questions can be posted to Networking Lounge, and if you can be on the Networking Lounge for the next 10 minutes, so you can answer further question on the topic. So thank you very much, everyone.
So I leave here and I go to the other,
the lounge, Networking Lounge, so you'll get the further questions.
Okay.
And the next session will start straight after this one for the audience. So thank you very much for everyone. It's and thank you for attending this session. Thank you for all speakers, and we'll move to the next session. Thank you.
Bye-bye.
Hello, everyone. My name is Ran, and I'm leading the value demonstration and affordability at Organon Minat. And I'm very happy to be introducing our esteemed speaker for the coming session, Advances in Contraception and Socioeconomic Impact. So we have today with us Dr. Christian Meschini. Dr. Christian is the chair and co-founder of CCHO, a Center of Clinical Health Economics and Outcomes Research. She has served in this role since 2016. Dr. Christian has over 25 years of experience in the pharmaceutical sector, and she is specialized in partnerships design and governance in biopharmaceutical projects, including managed entry agreements and collaborations in health data and registries development to accelerate innovation access to patients. She has a specific interest in the interface between policymakers, payers, academics, and industry leadership, and how collaboration benefit-risk considerations are managed effectively. Dr. Christiane holds a PhD degree in health management with high honorable class from Dauphine University in Paris and St. Joseph University in Beirut, and she has an additional master's degree in business administration from the Lebanese American University. Dr. Christiane is also a faculty member of the Superior Institute of Public Health at St. Joseph University Medical School in Lebanon. Dr. Christiane, thank you so much for being with us today, and we're looking forward to hearing from you.
Thank you very much, Ren, for inviting me, and thank you, Organon, for this organizing this interesting meeting. So I will start today presenting my talk, and as the title entails, it is mainly focusing on the economic impact of contraception, which is an extremely important topic, and it has gained lately a lot of more and more to the markets. So we're going to go over basically the importance of contraception and the SDG 2030 for the United Nations, and then the global contraception impact, economic impact. Then we will be more going into the various methods of contraceptives and their economic value, and then the comparative analysis between the different methods, and then we will be concluding the topic. So this is a topic which has been of utmost importance for the universal health coverage and financial planning, as well as the use and the importance use of contraception is the core part of this SDG. So basically, this is a kind of request from the United Nations, which was initiated in 2016 to support the use of contraception by all member states, and the importance of the support to the health of the mothers and the child. So unfortunately, even though this has been initiated and requested by the United Nations, this is not yet well achieved by member states. And as you see in this slide, you have, as you see in the slides, we have a very high unmet need in terms of family planning access in many countries, and this has been really exacerbated in low and middle income countries, as well as surprisingly in countries like Australia and New Zealand. So up to now, we still see a huge number of children and of mothers dying at birth, and this is mainly due from the unintended pregnancy, which is incurring worldwide and is a major cost driver for governments worldwide, even in the most advanced countries and the most developed countries like the US. So as we see in this slide, this unintended pregnancy cost has incurred the US a cost of about $85 billion, which is a significant budget for a government. And it has been really increasing over time, even though the rate of unintended pregnancy has decreased. This cost on unplanned pregnancies has also increased. So there is a major reason behind this increase in the cost of unintended pregnancy, and we are going to see throughout this presentation why this is happening. So the unintended pregnancy is not the only economic impact which is related to the presence or the non-presence of family planning. It is only the tip of the birds. The studies have shown, and a lot of findings from different countries, and this is data from the US, the economic impact of having or not having a global or mass contraception coverage in countries has major impact on families, has major impact on families and on children as well as on men. So as we see in this slide, there are a significant number of births non-planned, which has been reduced with having the contraception presence and covered in governments. And also studies have shown that there are better prospects for children, so better of substantial decrease in child poverty. So having contraception coverage and family planning in place in government has really improved the rate of child poverty, as well as for men who have partners who are using contraception. The studies have proved that they do really achieve more college degrees. So additional numbers from the US has also shown that there is really a better enrollment in college for women by 20% who have access to birth control. So 20% of women achieve college degree, and more than 50% now they are being part of law and medical schools because they have access to birth control, as well as more 8% benefiting from earnings in terms of in dollars. So this is all quantified not only for the government, but also for individuals and for families, as well as at large for the economy. So as you see here in this slide, apparently it looks like in the US there was a saving of $6 for each $1 of spending on birth control. So there's 6 times more return on investment for the governments in terms of savings if they do spend on birth control and on family planning. This is quantified in the US by $10 billion US dollars, which is a significant budget, as well as about $15.2 billion in terms of spending on maternity and infant care, and this is only for the Medicaid insurance in the US. So as we see from the data so far, spending on family planning, spending on access to birth control and on contraceptives has quantified benefits and has a huge return on investment to governments and to also individuals and families. Now, when we look at the contraception, there's a wide variety of contraception, as we know, coming from the conventionals to the most advanced, which are the long-acting reversible contraceptives. Studies have also now proved that the most effective ones are the long-acting reversible contraceptives, the LARCs. However, we will see that even though they are very effective, their use is not as optimal as it should be used, and there are still concerns about the impact of not having access to contraception in general and to these families. Now, I'm not going to go over the efficacy in my slides. I will leave it to the medical colleagues. I will be more focusing on the cost effectiveness on these drugs. So in my coming slides, I will be presenting studies which were really published not only at drug level, but at national level, comparing the cost benefit of different contraceptives marketed. So this is the first study from the US, which has been done and comparing 15 methods of contraceptives over 5 years of spending. And that it assessed the clinical and economic impact of the alternative contraceptive methods in the US. So the study findings, they proved that contraception in general, they do save cost on economy, they do save cost on the government. However, the modern contraception are the most cost-effective ones, and as we see in this slide, they are equally very cost-effective. Of course, the prices differ from one country to another and from one drug to another. However, in terms of cost-effectiveness, they are definitely more cost-effective than the conventional contraception. And that was proven as an outcome from unintended pregnancies. So number of unintended pregnancies avoided per person and over 5 years. So the second message was that they are also most cost effective, but even the conventional ones are also more cost effective than not having access to contraception. Even though the conventional ones, they do have a lot of failures, they incurred more cost on the government, even the unit cost is more costly, but because they do not cover and they do not provide the outcome in terms of unintended pregnancies as the new generation, they incurred more cost on the government. The oral contraceptives, they do lie in the middle between both parties. So the message here is that the contraception coverage and the family planning imposing the use of contraception and accessing the contraception access and birth control contraception is definitely a cost-effective measure in the US. Another big study from Australia, and as I mentioned in the beginning of my slides, that Australia is still lagging behind in terms of family planning things. So here, as we see in this slide, in Australia, they noted that the long-acting, the LARCs penetration is not aligned with the international standard, which is about 14.8%. So they, in the study, they studied and they modeled over 5 years as well, the introduction and the increase of the LARCs use from the current percentage to 14.8%. And they did this on 2 scenarios. They have modeled this on 2 scenarios. The first scenario was for women who are already using the oral contraceptive pills. And the second scenario was for women who are at risk of pregnancy, however, they are not using contraception. So through the model and through the analysis proved that in both scenarios, there was a saving on the government over 5 years if the LARC penetration has increased in terms of use. But this increase and this saving has been more pronounced in the scenario 1, where women are currently using the oral contraceptive, and the saving was in the amount of about $74 million. So as we see that even though the LARCs unit cost is more costly than the oral contraceptives, the increase of LARC use has incurred a more saving on the government. This saving has also been seen with women who are not using at all contraception. And there was a saving in terms of money of $2.4 million over 5 years. So this is another evidence, in addition to the US one, of the cost effectiveness of using the LARC instead of the conventional, or of using the LARCs versus non-use at all. Another interesting study, which was also done at a national level in Spain, and this study also did model the comparison of people who are using, of women who are in the childbirth age and who are intended to use contraception. So the rationale behind the study was initiated actually by the government. It was a model over 5 years, considering the main healthcare costs when using a contraception. And the rationale behind it is that even though the government is covering contraception and there is a good family planning for contraception in Spain, and the population has open access to birth control, there are still a lot on cost on unintended pregnancies and cost at large on the government, which is related to non-intended pregnancies. So they tried to see what was the reason behind this, and they did this. Who did draw the real practice, what's going on in Spain. And as we see in this slide, that the major cost is coming from the conventional contraception. And the most, a big part of the population is still using the old conventional contraception at a time where the percentage of unintended pregnancy does really is minimal with the implant family, and with the new, of course, modern contraception. So basically, it was an interesting study because it showed that the major cost, again, from non-coverage of contraception comes from unintended pregnancy, which accounts for about half of the cost. And apparently, it looks like the population is still using conventional contraception, which is incurring higher incidence of unintended pregnancies, which in turns leading to higher cost. And the lowest cost is coming from the new generation, or from the modern contraception, namely from the LARCs or from the implants. So it's another evidence about at large, and all these studies are studies which are done at national levels, which were initiated mainly by governments and by payers and by insurance institutions. And also it shows the same message, which is contraception is cost effective and LARCs are more cost effective than the conventions. The last study which I'm showing is for countries in the low middle income countries, and it was mainly also done as a modeling over 35 years through Markov model. And they wanted to see that if there is a large and there is a full demand, meeting the demand for modern contraception in Ethiopia in comparison with the current baseline, how would that impact the cost on the government? So it was taken as hypothetical 1,252,000 women, and those women were coming from different wealth backgrounds. So again, the same message came out from the study in low middle income country, and it showed that meeting the demand for modern contraception for the population at large by the government over 35 years is cost effective, and it resulted in about 676,000 quality adjusted life years, which means that for this number of women, which was hypothesized in my previous slide, which was 1,252,000 women, we have about 676,000 quality adjusted life, which is a marker in cost effectiveness, and which means that those 676,000 women living a great quality of life and with the number of years. And there are about 2,300,000 unintended pregnancies saved and 300,000 induced abortions avoided. So the outcome for the cost effectiveness studies was extremely a good outcome. 9,000 pregnancy-related deaths which were averted, and 40,000 cases of healthcare expenditure prevented from the pool. So again, it's an extremely interesting data, and it's a new study which was recently published on this low and middle income countries. And again, as you see in this slide, I mean, a lot of numbers. I will not go over all of them. But the outcome from the study, which was an extremely important outcome related to unintended pregnancies, to pregnancy-related deaths, to induced abortions, all these were reduced over time if the government to implement family planning and to do mass coverage for contraception and access to birth control. Again, the data not only showed that the outcome in terms of outcome was achieved, but also it showed that really the ICER, which is the incremental cost effectiveness ratio, was really below the willingness to pay for the government. So again, this is an extremely important number for the government and for the policymakers, because they saw in this model, which was an extremely well-designed model, that investing on contraception on the long run would save the government a lot of money, and also, of course, it would save a lot of deaths, a lot of abortions, a lot of complications. So as you see in the slide, the willingness to pay was above the cost effectiveness ratio, and it was an extremely positive outcome. So again, as you see in the studies, which I tried in my presentation to summarize from each of the continents, whether from the US, Australia, and Europe, as well as other income countries, studies which were done at national level, they did really prove that the direction is to go for LARCs, the direction is to go for contraception, and also this is not costly at all. This will save a lot of money on the and it will incur a great outcome, and it will of course meet the SDG of the United Nations. So I will try to conclude with just showing that because of all this data, the LARCs and the modern contraception is supported by international organizations. So as you see in the slides, globally, whether from the US or Canada, we have all the American Academy of Pediatrics, or the Center for Disease Control and Prevention. Europe, you have the HTA bodies, whether NICE or whether HAS. They do all support the use of LARCs, and they do reimburse LARCs on their formulary. So not only these, but also, of course, the WHO, the Family Planning Collaboration, all these international collaborations, they do acknowledge that contraception in general is cost-effective, but also LARCs are more cost-effective than the conventional contraception. And not only the policymakers or the HTA bodies, but also the medical communities, all the medical associations, the societies, they do acknowledge that there should be LARC and integration of these drugs in the healthcare system. So to conclude my presentation, it's definitely still an unmet need. We still have an average of 800 women dying daily from unintended pregnancies issues. This can be prevented if governments do decide to invest on contraception. So the meeting, really meeting the demand for modern contraception in low middle income countries is consistently a cost-effective strategy. It's still an unmet need, and LARCs prove to be the most cost-effective contraceptive methods, and they are definitely recommended by global organizations and HTA bodies. So thank you very much for your attention, and I will be happy to answer any question.
Thank you so much, Dr. Christian, for simplifying the economic data, which can be too much complicated. And it was very interesting to see that investing or increasing access to contraception is not increasing the cost or the burden from an economic perspective, but at the contrary, it will help us to save costs in addition to improving the health outcomes of the mothers and the babies and enhancing the economy of the society. We have actually questions from the audience. So from the economic studies that we have seen from you, where do you believe the government or the payers need to leverage to save costs? And you have also mentioned that despite the LARC being the most maybe cost-effective method, we are still seeing a low penetration rate. What are the reasons for that?
Yeah, thank you, Ren, for the questions. Actually, as you see from the presentation, it looks like the government, they need to look at the major cost driver from this issue, which is unplanned pregnancies or unintended pregnancies. So these outcomes are really outcomes that need to be quantified, and they need to look at it and not looking at the individual costs which are related to birth control complications. So what I would think that from the data that we have presented, in each country there should be an economic study done by the government and initiated maybe by stakeholders who are interested in doing this, whether the medical societies, whether manufacturers who do develop contraception, or sometimes from advocacy groups, or possibly from the UN agencies who are really supportive to this. They need to show the saving of introducing these laws. That would be a very important policy recommendation. Another thing is increasing awareness. So apparently from the studies, it showed that LARCs are used less in a specific age population. So they are used more in population which is 35 years and beyond. And the unintended pregnancies are mostly present in the age which is earlier. So there should be more awareness from medical societies, from advocacy groups, or from manufacturers and governments on the importance of going to something which not, just taking contraception, but taking the right contraceptions, because they proved to be reducing more the unintended pregnancy than the conventional ones. And of course, the government in parallel should give access in terms of cost for these drugs. So there should be a kind of comprehensive strategy from the government in order to improve. Because as you notice in Spain, although there is there's a mass coverage for contraception, the population is still using the conventional ones, and the cost on the government is still high. So from the study which was done in Spain, it showed that the government is not optimizing the use of the access, and the major cost is coming from the conventional contraception, and particularly from the rate of unintended pregnancies and the cost of it. And the same data was driven from the US, which also showed that even though the rate of unintended pregnancy has been reduced, but the cost is still high, because the contraception use is not being optimized by the population. So I would say these are the recommendations from the studies which were presented today. Yeah.
Thank you so much, Dr. Christian. And definitely we would agree that in order to improving the health outcomes from one side and impacting positively the economic perspective, so we need to work all together, and it is a multidisciplinary approach in order to succeed in increasing access to contraception while increasing awareness, improving the health outcomes, and decreasing the cost on the government and on the societies. On behalf of all Organon team, I would like to thank you for this insightful presentation. And if anyone has any question, Dr. Christian will be very happy to meet with you in the networking lounge in a while. Thank you so much, Dr. Christian.
My pleasure. Thank you. Bye-bye.
Thank you.
Good afternoon, dear doctors, and welcome to the second half of our contraception session. Welcome to the second edition of OSCAR Congress, Organon Scientific Congress across the region. My name is Walid Rahal. I am the brand lead for Women Health Business for Organon, managing fertility and contraception portfolio. I am very thrilled to introduce our moderator for the next session, Dr. Mohammed Ferghali. Dr. Mohammed Ferghali is Associate Professor of OB-GYN from Ain Shams University in Egypt. He is also consultant of OB-GYN Maternity Sabah Hospital in Kuwait. He is editorial board member of BMC Women's Health and associate editor of Frontiers Reproductive Health. So, Dr. Ferghali, please, the floor is yours.
Thank you, Walid. Good evening, everyone. First, I want to thank Organon for organizing this marvelous scientific event. This is our session 4, and our speaker today is Dr. Fadi Mirza. Dr. Fadi is a consultant of obstetric and gynecology and consultant of fetal and maternal medicine in Latifa Women and Children Hospital in Dubai, and he is the director of the department. Dr. Fadi received his medical degree from the American University of Beirut in Lebanon. He completed his 4-year residency in Obs and Gynae at Tufts University in Boston. Dr. Fadi is a fellow of the American College of Obstetricians and Gynecologists. Dr. Fadi did a fellowship in maternal and fetal medicine at Vagelos College of Physicians and Surgeons, Columbia University in New York, where he was a part of the faculty and presented countless scientific abstracts along with numerous published peer-reviewed articles. Dr. Mirza is adjunct professor in Columbia University College of Physicians and Surgeons. Dr. Fadi has extensive experience in maternal fetal medicine, especially high-risk pregnancy and morphological ultrasound. He is the recipient of many awards, including the prestigious Award of Research Excellence of the Society for Maternal Fetal Medicine in USA. Dr. Fadi is a clinical professor in Mohammed bin Rashid University College of Medicine, and he is the president of Emirates Fetal Medicine Society. Dr. Fadi will talk today about the role of LARCs in contraception, the longer-acting reversible contraception. Thank you so much, Dr. Fadi, to be with us today, and the floor is yours.
Thank you very much, Dr. Muhammad, a dear friend and colleague, for the kind invitation. Thank you very much, Walid, and the entire Organon team for their kind invitation. It's a great pleasure to be with you today. And as you see, the topic of my presentation is going to be the role of LARCs in contraception. This is clearly a topic that's very dear to our hearts, very basic. It's something that I think many of you among us delivered this lecture to students, to the residents, to fellows. So what I'm going to do is really just a refresher of this topic. It's been a while since many of us have, revisited this day-to-day topic, and at the same time tackle few points that are of clinical relevance. For the sake of our French-speaking colleagues, there will be translation, as I was informed, and I'll try to go as slow as possible to allow for prompt translation. So I'd like to start with this nice, elegant schematic, which really looks at the various menu that includes a long list of contraceptive options. And as you see, the top part represents the most effective ones, including implants and IUDs, as well as the irreversible ones, which are vasectomy and tubal occlusion. Just below them, we have a wide variety of moderate, let's say, efficacious products, including the injectables, the pills, patch, etc. And then, of course, we have the least effective towards the bottom, which include withdrawal, condoms, diaphragm, etc. This is a very nice way to also look at the myriad of options that we have when it comes to contraception in the office as well as in the hospital. You see this is a nice schematic that looks at the different methods as a function of typical use, perfect use, as well as continuation. And these are the clinically pertinent variables when it comes to our patients. We want to know when they typically use it, how often do they experience pregnancy? In other words, the method fails. What is this number with perfect use, which is, when we expect the method to work perfectly well. And finally, the continuation, because I do care, even if it works very well, but the patient doesn't like it, obviously, I'm failing. I think you agree with me that the lower part of the table here has more appealing numbers, particularly when it comes to perfect use and continuation rate. But I think you also agree with me that when we want to look at the typical use as well as percentage of continuation, the last four are really what we're looking for. And these interestingly include the two LARCs, long-acting reversible contraceptives, namely the IUD and the Implanon, as well as the two well-known irreversible methods, which are female sterilization and male sterilization. If I want to focus our attention today on the reversible ones, because obviously the irreversible is something that is specific to specific people, it doesn't apply to everyone, then we are left with the two methods, IUD and the implant. And indeed, the American College has dedicated a practice bulletin to long-acting reversible contraception, LARC, stating that IUD, or intrauterine devices, and contraceptive implants, also called LARC, are the most effective reversible contraceptive methods. And by going back to the table that we looked at together, this makes total sense. The major advantage of LARC, really, compared to other reversible contraceptive methods such as the condom or the pill or the patch, is that they do not require ongoing effort on the part of the patient for long-term and effective use. And this is why the typical use as well as the perfect use are pretty much the same, because we're not relying on the patient. And finally, a point that's very important to our patients, after the device is removed, ACOG really reassures us, just like all professional societies, that the return of fertility is rapid. This is a nice publication back, in 2015 that is called the CHOICE Project. The CHOICE Project is really about giving the patient the choice. So this was an observational cohort study that provided each participant with a reversible method at no cost. Patient got to choose, and they were eligible if they met the following criteria. They were 14 to 45, they lived in St. Louis in the US, they were English or Spanish speaking, they were interested in reversible contraception, were sexually active, did not desire pregnancy in the next year, so in other words, long-term desire, and were not using any contraceptive. They were all counseled in a standardized manner by trained counselors who really presented the methods from the most to the least effective, so pretty much using the table that we looked at. Then they received the contraceptive method of their choice at no cost. So whichever method the patient wanted, she got it. And those patients were interviewed at 3 and 6 months, and then every 6 months for the duration of the study. The data collected was quite vast, but primarily focusing on satisfaction, side effects, sexual behaviors, change in reproductive plans, and unintended pregnancy. Interestingly, when you look at the results of the CHOICE project, you could see that 75% of participants actually chose a LARC method, which is very important to us when we counsel our patients or when we discuss our patients. Patients, when empowered, financially, psychologically, well-informed, well-counseled, they're probably going to opt for a LARC method in the vast majority of times. In fact, when they look at the patients who were 25 years or older, the uptake of LARCs was even higher, reaching about 80%. About continuation rates, the continuation rates were significantly higher with the LARC methods compared to the non-LARC. So you see towards the top, the continuation rate at 12 months for the LARC was about 87% compared to 57, and the 24-month was 77 compared to 41%. And you can see the breakdown of the various methods underneath. How about the failure rate? Does it really correspond to what I just presented when we looked together at the table? Yes, when we looked at the LARC methods, you could see here that the failure rate at year 1, year 2, and year 3 was significantly lower compared to the non-LARC methods. We're talking about 0.3%, 0.6%, and 0.9%. And this is why we probably would understand why those patients are electing to proceed with these methods. So a couple of words on IUDs, then a couple of words on implants before we conclude our talk. So when it comes to intrauterine devices, they've been around since the beginning of life. We've had them appear back in historic reports. They come in various shapes and forms. Unfortunately, the more contemporary IUDs look less scary. They look more appealing to us as clinicians as well as to our patients. IUDs are indeed the most commonly used method of reversible contraception worldwide. They're used by about 1/4 of female contraceptive users with a wide range depending on the country. IUDs have gained popularity due to their high efficacy and safety, as well as ease of use and low cost. They offer a non-surgical option that is as effective as surgical permanent contraception. So often the patient is given the choice. Do you want a reversible or an irreversible? And she's going to ask us, well, are they equally effective? And yes, for the most part, they are. So it's no surprise that many times the patient would elect to pursue a LARC, especially if she is unsure of her future childbearing plans. When it comes to IUDs, there are two available types. We are all familiar with those, the hormonal and the non-hormonal. Non-hormonal being the good old copper IUD, which contains copper, and it's approved for the longest duration, which is 10 years. As for the levonorgestrel or the hormone-containing IUDs, these are available in a number of brands, namely the Mirena, which is approved for 8 years, the Liletta, approved for 6 years, the Kyleena, approved for 5 years, and the Skyla, approved for 3 years. And the nice thing about the different kinds of IUDs is that they can offer different options to different patients, depending on the duration of the contraception that they are interested in. And I think in this part of the world, Mirena is the well-known one in our clinical practices. This is a nice schematic that looks at the various IUDs, comparing the copper IUD to two forms of levonorgestrel, including the Mirena. You see here that the duration of therapeutic effect is highest for copper. So if a patient asks us, doctor, we want the longest, we want to forget about contraception, the copper one is probably the best option. And you can see here that the pregnancy rates are very comparable to what we discussed earlier. How does the IUD work? This is a nice table that really looks at the way that the IUD works. So method of action. We all know it's changes in cervical mucus. It's the chronic inflammatory changes in the endometrium. It's the atrophy in the endometrium, and at times direct oviductal effects. Which one? The patient is going to look you in the eyes and say, doctor, is it the copper or is it the hormonal? And here we have to go over a checklist, a basic checklist. What's the patient's preference? Does she care about having a period, quote unquote, or having cyclic bleeding? Does she prefer lighter periods or even amenorrhea? Is she tolerant of unscheduled, unpredictable bleeding? Does she want to avoid hormones? I'm sure you all agree with me. We have those patients who look at you and say, like, doctor, no hormones for me. Of course, take some counseling, but you have a number of patients that do not desire hormonal therapy, or we don't want them to take hormones, as we're going to see. Presence of heavy menstrual bleeding, presence of dysmenorrhea. These are all factors that we should take into account when we want to give the patient the choice. Reasons for patients or us to choose copper IUD: if we want to avoid exogenous hormones, whether it's a patient choice or our choice, for example, in patients with history of breast cancer, where really you don't want to take any chance. Continuation of pre-IUD bleeding pattern. We know that the copper IUD does not lead to amenorrhea, does not cause anovulation, so patients are more likely going to have cyclic bleeding. And the desire, as I mentioned, for the longest term contraception, obviously the 10 years comes with the copper IUD. How about the levonorgestrel IUD? We know that it leads to a reduction in menstrual bleeding and anemia, so it's a good option for patients with heavy menstrual bleeding. It can even lead to amenorrhea in a number of patients, which would be appealing to us in a number of clinical scenarios. A reduction in dysmenorrhea, so that's an indication. And finally, treatment of endometriosis relating to pelvic pain, and even treatment of endometrial hyperplasia. We often get asked in the clinical setting, doctor, is there an increased risk of PID? Earlier studies have reported an increase in PID. However, these studies were flawed, and we now know there actually no increased risk of PID, although we have to acknowledge that the initial insertion is associated with that slight increase while during insertion. This is why some have advocated for the use of antibiotics, but later on we know that there is really no increase in PID, and the same applies to HPV. Ectopic pregnancy is also something we often talk to our residents and our students about. The absolute risk of pregnancy with an IUD remains very, very low, but we do have to counsel the patients that in the event of pregnancy on the IUD, there is an increased risk of ectopic, and this is an important take-home message. Infertility, no evidence of increased risk of infertility among IUD users. Let's switch gears now and talk about the second LARC, namely etonorgestrel implant or Implanon. It's a progestogen-only implant that's preloaded in a disposable, sterile, single-use applicator. It is placed subdermally, and it's a long-acting hormonal contraceptive, effective for up to 3 years. I've personally used it back in my days in the US for many, many years, and it was among the most popular alongside the IUD. Implanon was the first generation, and then Implanon next was the newer version, and trials on both have been very popular in a high number of countries, 17 for Implanon, and the newer version was studied in 6 countries, and we know it's FDA approved just like the IUDs. The implant is about 4 centimeters long, and it works by inhibiting ovulation as well as changing the viscosity of the cervical mucus. When it comes to its effect on ovulation, the first thing that the patient would ask about, or some colleagues would ask about, is, okay, doctor, you just mentioned that it inhibits ovulation. Will the estradiol concentrations drop with the placement of the implant or Implanon? The answer is no. This has actually been looked at back in 2000 in this study that looked at the estradiol concentrations, and we could see that they remained above the level seen in the early 2 follicular phase. Another question that we often get asked, any effect on the bone? Well, in the same study, the bone density remained unaltered over 2 years with no detectable difference between the 2 groups, the copper IUD as well as the Implanon. And why did they choose the copper IUD? Because it's an inert method. When it comes to efficacy, most of the trials report a cumulative effectiveness rate of about 99%. A couple of important clinically relevant points relate to actually the weight. So we often get asked, doctor, in your experience, does the weight affect the efficacy of the implant? Well, yes, we believe it does. We cannot exclude that the contraceptive effect in these women, we're talking about obesity, we're talking about morbid obesity here. We cannot exclude that it does get altered. So many of us, and this is an expert opinion only, would err on the side of replacing the implant earlier. And another clinically relevant point that we often get asked about is, will the same medications that affect the efficacy of oral contraceptives also reduce the efficacy of the implant? Probably, yes. Again, it's an expert opinion, and caution need to be exercised with some of these medications, especially the psychiatric ones. Bleeding pattern. We talked about bleeding pattern with IUDs. Is there a change in the bleeding pattern with the implant? Well, yes, women are more likely to have changes in their bleeding pattern. These may be related to the bleeding frequency or intensity or duration. And an important take-home message here is that the bleeding pattern that's experienced during the first 3 months is pretty much predictive of future bleeding pattern for many women. So if a woman tells you know what, doc, my first 3 months on the implant were horrible, probably it's not for her. But if a patient does pretty much well during the first 3 months, we can reassure her that she's probably going to be fine for the duration of the treatment. When it comes to the bleeding pattern, it's important to note that we have a wide spectrum, but 1 of 5 women will report amenorrhea. But on the other hand, 1 in 5 would report frequent and or prolonged bleeding. How do we overcome patient dissatisfaction? Counseling, counseling, counseling. It's very important to set the expectations of the patients straight from the beginning. When it comes to data on that, there's a very elegant study that combined data from 11 clinical trials with nearly 1,000 patients. It was an open label design. They looked at the frequency of bleeding, spotting, and bleeding free over a duration of 90 days. And in this study by Mansour et al., the numbers were as follows. The mean bleeding/spotting days was about 17 per 90 days, and the number of episodes was about 2. So this is something to kind of help us counsel the patients well regarding the first 90 days. Safety and efficacy, I know it's a busy slide, but this is another study by Darney et al. That really looked at the safety and efficacy, as I mentioned, from those 11 clinical trials. The most important point is something that I just presented, which is that the implant is efficacious and a safe method, and all what it takes really is counseling and counseling and counseling. The numbers are in favor of the implant. It's just about making sure we set the expectations straight. Why? Because if we do so, the rate of discontinuation is probably going to be improved. It's already a good number. This is the discontinuation rate, year 1, year 2, and year 3. And as you see, that if the patient does well with the implant, the chances of discontinuation by year 2 or by 3 is quite low, especially by year 3. So really, the biggest challenge is overcoming year 1. How about us? We know patients like it. We know data is in favor. How about us as physicians? Well, this was looked at by Mansour et al. In this open label study, 23 investigators, experienced and inexperienced with the implant, performed the procedure. And the results when the investigators were surveyed was that they were satisfied with the first insertion onward. All were satisfied or very satisfied after 12 insertions. So definitely there's a learning curve that we need to acknowledge, but the satisfaction was quite high. Only 2% of insertion were considered difficult when it comes to skin puncturing and or sliding of the needles. So only 2%. So in conclusion, yes, the satisfaction by physicians was quite high as well. When should we avoid the implant insertion? The typical things that we're all familiar with, things that make sense: known or suspected pregnancy, active venous thromboembolic disorders, known or suspected malignancy. When it comes to sex steroid sensitive malignancies, presence or history of liver tumors being benign or malignant, hepatic disease, undiagnosed vaginal bleeding, and finally hypersensitivity to any of the substances included. I'm going to end my talk with a few quick points that are derived from ACOG's recommendations and things that are really important to us as clinicians. Nulliparity, it's something that we talk about often and we get asked by patients often. Doctor, I'm a nulliparous lady. Can an IUD or an implant be used in my case? The ACOG, among other professional societies, clearly state that IUDs and contraceptive implants should be offered routinely to nulliparous women as safe and effective options. And the US MEC assigns category 1, in other words, no restriction to the use of the implant by nulliparous women and adolescents, which are a vulnerable group that we should really keep in the back of our head. As for the IUDs in the same group, it's also a category 2. In other words, advantages outweigh the risks. Timing of insertion, I know many of us have historically erred on the side of placing the IUD right after the period, but when it comes to the recommendations, IUD and implant can be used at any time during the menstrual cycle as long as pregnancy be reasonably excluded. Effect on menstrual cycles, what does ACOG state here? Again, the same point that I mentioned, counseling the patients about what to expect with each method. Antibiotic prophylaxis, when it comes to IUD insertion, we talked about the point of PID. Routine antibiotic prophylaxis is not recommended before IUD insertion. It has not been shown to decrease the likelihood of PID or the IUD removal rates. Another way to look at the eligibility of patients to LARCs comes from the WHO guidelines. The WHO include 4 categories. Category 1 refers to or includes a condition for which there is no restriction for the use of a contraceptive method. In other words, sure, go for it. Category 2 would refer to a condition in which the advantages of using the method outweigh the theoretical or proven risk. Category 3 would include conditions in which the theoretical or proven risks outweigh the advantages of the method. And finally, category 4 refers to conditions that represent an unacceptable risk if the method is used. So clearly, we're better off with categories 1 and 2. We should avoid category 3 and we should avoid category 4 at all costs. So what do we do when it comes to venous thromboembolism and the overview of the various methods? So as you see, when it comes to LARCs, history of VTEs does not preclude the use of LARCs, particularly the copper IUD, but also the implants and the levonorgestrel. When it comes to acute VTE, you probably want to avoid it, especially if the VTE occurred acutely at or on the method. When it comes to chronic, we're okay. So bottom line here, history of VTE or chronic VTE, you're good to go with the various LARCs. Cardiovascular disease, stroke, no problem with LARCs. You could look here and see that OCPs and injectables are a big no when it comes to strokes. Same thing applies to ischemic heart disease. Yes, we can use LARCs. And finally, having different risk or multiple risk factors for cardiovascular disease, you want to avoid the combined hormonal contraceptives and injectables. But yes, you are welcome to use the LARC. Other high-risk conditions, such as hypertension. For controlled hypertension, you could see that category 1 for all LARCs. Uncontrolled hypertension, 1 to 2, so we're still okay. Certainly avoiding the other options. When it comes to obesity, no problem with the use of the LARCs, but again, we may have to make some modifications as I touched upon earlier, and diabetes, no problem, category 1 to 2. Postpartum, we often get asked, clearly the OCPs and the progestin only injectables are a big no here. But when it comes to the LARCs, all the LARCs are okay to use starting 4 weeks onwards. Smoking, I think this is something that we often talk about, or we've learned since our early medical school days. OCPs above 35, no, we cannot use with smokers. But when you look at LARCs, regardless of age, smoking is not a contraindication to any of the LARCs. Another important point, migraines or headaches in general, you could see that both non-migraines as well as migraine headaches are not a contraindication to the use of all LARCs. I will end my talk with a reminder of the menu of contraceptives, focusing our attention on the various LARCs. It's easy to tell, and I hope I demonstrated to you that it appears to be the most efficacious and the most satisfying to patients and the safest. And remember one thing, there's no shoe that fits all. So the more options available to us, the more options we can offer to our patients. And this way we can ensure patient satisfaction, patient safety, and achieving of our goal of contraception, which often saves lives, as you all know. And thank you very much for your attention.
Thank you, Dr. Fadi, for this valid, clear information about the LARCs and sharing with us studies showing the evidence of the use of implants. I will start.
Thank you.
Welcome, Dr. Fadi. I will start the questions by my question. If I counsel a patient about the LARCs and she asked me if the Kaba ICD can do the job alone, why to use Mirena?
Very good question. So I think, Dr. Muhammad, there's no shoe that fits all. I think it's all about counseling. That patient might be somebody who has heavy menstrual bleeding to start with. So Mirena might be a better option for her. She may suffer from debilitating dysmenorrhea, so Mirena might be better for her. So I think it's all about the patient characteristics, patient counseling, and finding which one is better. If there is really no specific indication for one or over the other, then obviously the copper IUD would offer the longer term one and would be appealing to patients who are done pretty much with childbearing and want something that would stay for 10 plus years.
Okay, Dr. Fadi. The other question regarding the obesity. You said that in obese women, we must replace the implants before 3 years. What do you think? At what time and what we can do to know when to replace the implant?
It's a very good question, Dr. Muhammad. I don't think any of us know the answer. It's an expert opinion to say that it's a good idea to remove it earlier. I think if we're dealing with morbid obesity, it's reasonable to remove at 2 years rather than 3 years. But again, anyone might come out and disagree and say, oh, there's no studies, you can continue to 3, and it's a valid point. But if you want to be conservative, I think it's reasonable to stop at 2 years and replace it at that time. And this way, you can just try to avoid that, at least theoretical risk.
Yes. Thank you, Dr. Fadi. Another questions about the contraception in Emirates. She said that insurance not cover all the contraception, even consultation, and all are so high prices. Also, we have over 200 nationalities. Still, contraception is a problem.
It's
from
true.
In Emirates, what you experience?
Yeah, it's true, Dr. Muhammad. So, I think contraception is regarded as a luxury, and if you look at insurers and insurance company or insurance plans, most actually shy away from preventive methods. And yes, today we are dealing with companies that would not even cover a pap smear because it's considered preventive. It's considered it's not necessary. So by the same token, I'm not surprised that many insurers would not cover contraception in general. And yes, they are expensive. I'm going to seize that opportunity to bring up an important point. When we look at the price of LARCs compared to non-LARCs, the price per unit is higher, but we have a number of cost-effective studies that I removed for the sake of time from the presentation that really looked at the cost effectiveness long-term. And actually with LARCs, you are saving money. So instead of, just going to use an example, instead of paying 3 years worth of OCPs, you're paying the price of one implant, for example. The overall cost is going to be significantly lower. And I think this is something that we all relate to, and it has been supported by data.
Yes, Dr. Fadi. I am always happy to hear you and to be with you in meetings. Thank you so much for your presence today in our session. And further question can be posted in the network launch, and Dr. Fadi is happy to answer your question if you have any. Thank you.
Thank you very much, Dr. Ahmed. Thank you very much.
1 minute and we will move to the next session, inshallah. Hi, everyone. Welcome to the session 5 of the Version 2 of OSCAR, Organon Scientific Congress across the region. Our speaker in this session will be Professor Gamal Mustafa. Professor Gamal is a consultant of obstetric and gynecology in Alia International Hospital, Kuwait, and he is the head of the department. Dr. Gamal received his medical degree from Ain Shams University, Cairo, Egypt in 1995, and he is a professor of obstetric and gynecology in Ain Shams University since 2012. Dr. Gamal was licensed as consultant for obstetric and gynecology in Egypt, in Kuwait, in Sudan, and in KSA. Dr. Gamal had experience in work of the Gulf region for more than 20 years, and Dr. Gamal had experience in setting up and management of hospital and IVF centers. Dr. Gamal will talk to us today about the post-LAC insertion patient counseling. Thank you too much, Professor Gamal, for being with us today, and the floor is yours.
Thank you, Professor Muhammad. It's my pleasure to join you in this short talk. Actually, I will talk about the post-LAC insertion counseling, and I actually designed my talk to be suitable not only for gynecologists or professionals in contraception, but it will be suitable also for any general practitioner and any healthcare provider. Let us talk a short about what is counseling. Counseling is the provision of professional assistance and guidance in resolving personal or psychological problems. Counseling is a collaborative effort between the counselor and the client. It is a strategy to empower women who don't desire pregnancy.
Dr. Gamal, please, can you share your screen?
I share it already.
You don't see your screen.
Sorry. Is it okay now?
I can see it.
Okay, I will start again.
Yes, please, Dr. Gamal.
Yes, okay. So when we talk about counseling, it is a provision of professional assistance and guidance in resolving personal or psychological problems. Counseling is a collaborative effort between the counselor and the client. It is a strategy to empower the women who don't desire pregnancy to choose a method of birth control that she can use correctly and consistently over time, thereby reducing her individual risk of unintended pregnancy. The long-acting reversible contraception, as Dr. Fadi explained, is mostly the intrauterine contraceptive device and the implant. Both are highly effective in preventing pregnancy, more than 99%, and they last for several years and are easy to use, and both methods are reversible. We will concentrate today about the post-implant insertion counseling, as this is an important issue because the IUD is longer used before the implant, and nearly everyone knows how to counsel about it. The after-LAC insertion care. First, after insertion, the clinician will ask the lady to feel the device under her arm skin. She should check this periodically over the 3 years. If she can't feel the device at any time, she should seek medical advice. Advise the user of the implant to keep the area of insertion clean and dry for 5 days. Don't push the device or play with it after the insertion. User may have a small scar at the insertion site. So this is the immediate care after the implant insertion. There is a follow-up documents. The user will be given a card with the dates of insertion and must retain this to ensure that the implant removed at the appropriate time. If user like the implant removed earlier, then she must book with a clinician to discuss. If user lost the card, she can contact the medical center as she will not be routinely reminded by the expiry date of her implant. When does it start working? There is one of the questions usually asked by our clients. The implant is immediately effective if inserted during the first 5 days of a menstrual cycle, which starts with the first day of the bleeding. If the implant is inserted after 7 days, the implant is effective after 7 days if it is inserted at any other time in the menstrual cycle. Other contraceptive measures such as condoms or abstinence should be used for these 7 days. One important thing, the implant does not protect against sexually transmitted infections or bloodborne viruses. Practice safer sex. Condoms reduce the risk of sexually transmitted infection and the bloodborne viruses. What are the benefits of the implant? This is one of the counseling important points to be explained to the client. It is highly effective. It lasts a long time. It is reversible and the return to fertility is rapid. It does not need the user to remember to take a pill every day. It is a cost-effective method of contraception. It may reduce painful periods, premenstrual syndrome, and acne in some users. Can medication impact the effectiveness of the implant? We have also to get our clients that the implant is affected by enzyme-inducing drugs, such as barbiturates, carbamazepine, phenytoins, and rifampicin. The patient medication history should be checked prior to being commenced of the implant, and the user should also be told to make other clinicians aware of their implant before starting a new medication. Call your doctor at once if you have. This is an important issue. The client must be instructed to call her doctor if she feels warmth, redness, swelling, or oozing where the implant